Our number one goal is to prevent the virus from spreading and becoming a community disease here in the United States. And so that's why we've taken a multi-layered approach, bringing the full force of the U.S. government to keep the American people healthy. And so what we've done is we've got restrictions on travel just to make sure that individuals who have been in the most impacted zones in China or who've been in China in the last 14 days have appropriate restrictions on their movement into the United States to prevent spread. We're also taking a multi-layered approach here within the United States with our world-class public health system. One thing we've just launched is a surveillance system using in 5 of our important cities, Seattle, San Francisco, LA, Chicago, and New York, using our flu surveillance network to ensure that anybody who presents with potential flu-like symptoms will also be tested for the China coronavirus as an early warning system.
And that sounds a little bit like exactly how the virus was detected in China. We know that through their flu season is what they were able to detect this, unusual occurrence. But speaking of that, there continues to be concerns about China's response and about their transparency specifically. It appears that they on their end they share the virus sequence pretty quickly. They quarantine their residents. They have the hospitals up and running. They've even fired party officials. But we also just found out that there were 13,000 cases that could have been underreported. So what are your response to that?
Well, China is facing an unprecedented health crisis, and so some of this may simply be the chaos involved in quarantining over 60 million people and trying to contain a rapidly evolving unknown virus spreading in your country. But we must ensure that the response is transparent and vigorous, and that's something the World Health Organization has got to ensure that China is held to account for transparency and cooperation by the same standards that they would require of the United States or any other country.
And there's concern that they're not doing that currently.
Well, I think it's an unknown. I personally offered as of January the 6th to send CDC experts in to assist the Chinese in answering the critical questions. How rapidly does this virus spread? What's the incubation period? Can it spread in an asymptomatic condition? All those types of questions we still don't have the answer to, and it's 39 days since I made my initial offer.
Are those conversations still ongoing? Are you still in touch with the health minister?
I am, and we are hopeful that China will be able to deploy a World Health Organization team with U.S. participation very soon. But they will have to have transparent access to the data and information to be able to try to work with their Chinese colleagues to get the answer to these and other critical questions, working really shoulder to shoulder with their Chinese colleagues, as we always do. They can't be just locked away in a conference room and handed sanitized data. They've got to really be there at the lab desk working with scientists.
I'm Angela Kiwani. Welcome to Yahoo Finance Presents. In this episode, we will be speaking with one of the world's top infectious disease experts and the face of the coronavirus outbreak in the U.S., Dr. Anthony Fauci. We discussed the current status of the outbreak in the country as states continue to reopen despite some problem areas, as well as the U.S. relationship with the World Health Organization and his thoughts on the global vaccine race. Dr. Fauci, thank you again for joining me. And I want to start with one of the most hotly debated topics right now, which is asymptomatic transmission. I'm sure you've heard the World Health Organization yesterday gave out some information from member states' data that suggested that possibly asymptomatic people are less likely to transmit the disease, and they were differentiating between asymptomatic and pre-symptomatic. So I'd like your thoughts on that.
Yeah, I think a lot of confusion has emanated from this issue of an asymptomatic person and asymptomatic transmission. When you look at the number of people, if you look at all the cases of coronavirus infection, about 25 to even up to 45% of the people are asymptomatic. The real question is, what is the percentage of infections that go from an asymptomatic person to an uninfected person? And that's something that we know it occurs, but we're really not sure exactly what the extent of it is, because it's very difficult to measure that. You can determine how many asymptomatic people are merely by doing screenings and finding out. But when you're doing epidemiology, so what What the WHO said yesterday, that although there are asymptomatic infections and although asymptomatic people can transmit, they are not the drivers of the outbreak. The drivers of the outbreak are people who are symptomatic and transmit to others. That doesn't mean that asymptomatic transmission doesn't play a role, but it isn't the major driver of the outbreak. And yet there's this confusion when people talk about who's asymptomatic infection and who's driving it. But that's really what the WHO meant.
Okay. And talking about confusion, one of the things that I'm sorry I have to ask you about is hydroxychloroquine. The retraction of that study in the Lancet last week, which caused the World Health Organization to pause their trials, was based on questionable information. So I'm curious, has that changed your opinion of it at all? I know you've called for more trials. And is there a difference between, the treatment version, treatment option, or the way the president is using it as a prophylactic?
Right. The answer will come with the clinical trials. I think there's a lot of back and forth about what is a good trial, like the one that was retracted or not. I think the important thing for us all to do is that I've said for so long and so many times is that the definitive proof whether something is safe and effective, whether it works or not, is a randomized controlled trial. Those trials are being conducted, and we will know the answer, and we will go with the science rather than going back and forth in things that are sort of suggestive but not necessarily definitive. As scientists, we want to go with the definitive trial.
Fair enough. Speaking of the World Health Organization, the president did announce that we are ending our relationship, the U.S., with it. Is it your sense that this is affecting the scientific community? We've obviously had collaborations globally for such a long time, either through the organization or outside. How is this disrupting that?
Right. The WHO is an imperfect organization, but it's an important organization. I've dealt with them over many outbreaks, over many years. We still interact with them. We have a weekly conference call where they bring together all of the different countries who talk and update us about exactly what's going on in their individual country. And that's important for us. That's not to say that they haven't made mistakes and missteps in the past, but in general, it's an important organization.
One of those missteps based on the U.S. Interpretation is the way that they handled the outbreak in China and holding them accountable. That is the reason behind President Trump calling for an ending that relationship. But their vaccine candidate is pretty far ahead, even though we have Moderna as a front runner. So if they do make it to production and successfully get that out there, is it possible we'll see their vaccine used in the U.S.?
Well, the answer is that there are a number of candidates that look really quite favorable, that are in various stages of clinical trial. My prediction would be that we would have more than one candidate that ultimately gets to the point of proven to be safe and effective. So I don't think we're going to have a situation where one country or one organization has a vaccine that they are or are not going to share with others. I believe that there will be enough favorable responses to the large clinical trials, and that the plans now to make hundreds of millions, if not billions of doses will actually come true. When that happens, it's very difficult to predict. We're on a course right now where we believe, at least in a couple of the candidates, that when we start the phase 3 trial, let's say in the first week or so of July of this year, that by the time we get to the early to mid-fall, there will be enough people accumulated in the trial and enough infections that we might have an answer by the end of this calendar year. That's for one of the candidates. There are other candidates that are ahead of that, behind that. We'll just have to wait to see what happens. But I'm cautiously optimistic. And I know that's a reasonable question that you ask. Is this one going to beat that one, or is the other one going to beat? But that's not what it is. It's a group of candidates, most of which actually have pretty good preclinical data. So we're counting on having success with more than one, we hope.
Dr. Fauci, your favorite phrase, cautiously optimistic, and you just used it. It's something you're very, very keen on using, and I understand why. But another thing you also say is that, like you just said, you're looking for that indication of being proven as a vaccine. And I think that sometimes gets condensed to there's going to be a vaccine this year. And while that is technically true, I think we should differentiate. And I'd like your thoughts on the differentiation on what that means for the general public, even if it is at risk, even if you produce at risk and you do get that indication. What does that mean for the general public versus, say, health frontline workers and essential workers?
Okay, so thank you for giving me the opportunity to answer that. It's a complicated question, but it's an important question. So first of all, everyone should understand when either I or other people talk about projections of vaccines, when you may or may not get it, you've got to realize there is no guarantee at all that we are going to have a safe and effective vaccine. We feel, and I'll use my terminology, cautiously optimistic that we will actually be successful. So we're counting on being successful. The rate at which we do it is something important. We say we're doing it very quickly and at risk. It isn't risk of safety. We're not compromising safety. We're not compromising scientific integrity. What we're doing is that we're going along at a pace where under the normal development of a vaccine, you would go to one step, wait to see if you're successful, then make an investment in the next step. Then when you're successful, make an investment in the next step. The reason for that is caution, because if you get stopped at this step, you don't want to have to waste all the money of the investment. Companies do that because they can't risk resources. Given the urgency of this situation, we've made a decision with the support of the federal government that we will proceed at risk. We will start making doses of the vaccine before we even prove it was effective. If it isn't effective and isn't safe, then the only thing that would have been lost is money. But we feel it's worth it to gain those extra months. And that's the reason why we're moving more quickly than usual, because when people hear quickly, they say, oh my goodness, are we compromising safety? Are we compromising scientific integrity? The answer is we're not. Given that, we project that we will be able, if we're successful, Anjali, and that's a big underlining, if we're successful, it is likely that we will have doses to be distributed to people by the end of this calendar year or the beginning of 2021. And then you ask, well, who's going to get it? Obviously, ultimately, you want everyone who needs it to get it. But the prioritization has always been you give it to the healthcare workers who are going to be deliberately putting themselves in harm's way to help people. They need to be protected. Then you have a number of vulnerable people, the people who have a greater chance of getting the complications of infection, the elderly, individuals who have underlying disease. And then you go down the line until ultimately you get everyone. That's what it is. And it's something that, again, we're aspiring for that. But when you're dealing with the development of vaccine, there's never a guarantee that you're going to get it.
Really quickly on that compressed timeline, do you see that being a change that might be adopted, after we get out of this as something that changes in R&D?
Well, it depends on the urgency and the need for a particular product. If you have 3 or 4 interventions, be they drugs or vaccines, and people are being well treated with it, and you want to add an additional one, it's very likely that that would not be on an accelerated speed because it isn't necessary. When you have nothing like we have now, we need a vaccine, we need therapeutics. Then you do the balance of proceeding quickly, but always safely with attention to the scientific integrity of the study.
Fair enough. I know that your work with the White House task force is ongoing. You've said that, even though we're not getting those daily briefings. So are you still regularly in touch with the president? Is it just the vice president showing up? And what is the main concern right now? What's the focus?
Well, it's both. I mean, obviously, I was with the president last week. I'm going down today, literally in a couple of hours, to meet with the vice president and the coronavirus task force, as well as meeting with the subgroup of doctors who are a component, but not the entire task force. So we still do it. I mean, the number of, when things were at their most intense during the major issue that we had with New York metropolitan area was dominating with infections, we were at the White House Coronavirus Task Force like every day, including Saturday and Sunday. That's not what we're doing now. We've certainly still have a very strong presence in the task force, but it isn't as visible. You don't see it as much because things that are concentrating on right now are how do we safely reopen the government? How do we get these cities, these towns, these counties to try to get some sort of normality, to get the economy back? That's most of what's being discussed. But the behind the scenes activity, concentrating on the health and other issues, that is as good as it's been.
Okay. What about testing? I know that's one of the issues. We've seen, the ramp up of production of swabs. Labs are increasing their capacity. All of the numbers are increasing, but we still hear anecdotally about sort of conservative use of these PCR tests specifically. So I'm curious on your thoughts on what the biggest hurdle remains to access to testing, as well as the at-home component, which some people are saying could address those health inequities that we're so focused on.
Well, I think the testing situation, first of all, is orders of magnitude better now than it was if we were having this discussion a couple of months ago or even last month. It gets better and better. We have more tests available. We have the associated material necessary for the test more available than they were. I screen a lot. I mean, in addition to the visible things you see me, usually late at night, I'm calling up people in different cities and different counties and trying to find out how things are going. And in the beginning, there was a concern that they didn't have this or they didn't have that. But now more and more, we're seeing that the kinds of things that were problems before are being solved. They're not all solved. They're never all solved. But it's significantly better than it was. In fact, I have a call tonight with constituents from a number of cities throughout the country who are in the trenches doing the things that we're talking about to try and get a feel for how it's been compared to a week or two ago.
Okay. And mass gatherings is obviously something that you're focused on in this reopening concerns. Are you concerned about the protest becoming super spreader events, as the CDC director suggested last week? And does allowing them, is it harder to reinforce sort of those social distancing measures as a result? Is that a concern?
Well, obviously, it's a public health concern. I mean, we all recognize the constitutional right and even the compelling reason, given the situations now of people expressing their thoughts in a demonstration. So it's not anti-demonstration at all. But you have to balance that with the public health imperative that we have to not spread infections. So you could tell people that it is going to be risky to demonstrate, but people will demonstrate anyway. You've got to be realistic. You can't live in your little cocoon and say, well, you shouldn't demonstrate, and yet they do. So our as public health officials, what we say, if you are going to demonstrate in a non-violent way, a peaceful demonstration, please be sure to wear a mask all the time. To say keep physical distance is a non-starter because the very nature of a demonstration, you see people in crowds. But wear a mask, and I know when things get animated, people start to chant and shout. Please resist the temptation of pulling your mask off. Leave your mask on if you do that.
Fair enough. And looking at, this is a little bit of a pivot, but looking at your experience with HIV, I know that's something that has been easy for you to follow that playbook when it comes to knowing what to do about contact tracing, with the HIV treatment cocktails, the idea of using Gilead's remdesivir in coordination with others. What are some of the other sort of experiences that you're applying from your time then?
Well, I mean, there are so many aspects of these outbreaks that are similar and so many that are very different. Let's take the scientific side. When we first saw the result of remdesivir, which was a significant effect, but modest in effect. So it was statistically significant, but it was a 31% diminution in the time it took to get back to recovery in the sense of leaving the hospital, because this was a study that we did in hospitalized patients with lung disease. It reminds me back, way back in the 80s when I was doing the same thing with HIV, and we had a single drug that looked like it was giving a good effect, and it did, but it was a single drug, and we needed to do better. And subsequently, over the period of time, we had a second drug, then a third drug. We did it in combination with two, and then finally, we landed on the triple combination that completely transformed the lives of HIV-infected individuals. And then from that, we developed a prophylactic, or a drug that if you give a single pill a day, it is highly successful in preventing the acquisition of HIV. So if you look at the analogies, that what we see now is a step-by-step improvement in the treatment, potential prevention, and then ultimately a vaccine. So there are analogies. One is a chronic infection that lasts over years. One is an explosive, highly transmissible. So they're very, very different. But the development of interventions really do have somewhat of an analogous pattern.
What about right now, where we are? You know, you've been watching, you've been updating us on every single, issue or update that we've needed. But are there things that maybe didn't pan out the way you expected, or things that you're still waiting to pan out?
Well, I mean, that's a very broad question. It's very, very difficult to apply it. I'm not really sure exactly what you mean when you say pan out. I mean, we're in a very difficult situation that we're dealing with literally a highly, highly transmissible virus, that it is so different from other viruses. When it was doing public health interventions, was modestly or relatively easy to contain. We know now that, and this came out yesterday in the news, that the shutting down of a nation, the way we did here in the United States and way virtually every other country, with few exceptions, did, was to lock down, was responsible for preventing tens and tens and tens of millions of infections. We've never been in a situation like that ever in history, where we had to essentially shut down the planet, is what actually happened. I mean, if you look at the globe and the more than 200 plus countries that have been afflicted, almost all of them had that shutdown. That is unprecedented. Right now, we're faced with a real challenge. You can't stay shut down forever. So it's going to have to be a balance between containing the potential resurgence, which we will hopefully have the capability of doing, at the same time as we march forward to some sort of normalization and reopening not only our country, but the rest of the world. Because if you look at what's going on, so many other countries are trying to do the same thing we're trying to do. The question is, we needed to do it prudently and safely in the context of our ability to respond when you do see these bit of resurgences.
And a final question, are you breathing a sigh of relief yet?
A sigh of relief? No. I never get ahead of myself. I'll breathe every sigh, as Yogi Berra used to say, it ain't over till it's over, and that's when I'll breathe a sigh of relief, when we're really completely out of this, right?
Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases, thank you so much for joining me today. It was a pleasure.
Good to be with you. Thank you for having me.
Joining me now is the Surgeon General of the United States, Dr. Jerome Adams. Thank you so much for joining me today, Dr. Adams. Great to speak with you.
Really glad to be here with you.
I know that it's a tough time out there with so much going on with the mask debate, especially as we're seeing so many cases rise across the U.S. and continuing to do so. Could you tell us about what the logic is and what the thinking is at the federal level about not requiring a mask mandate?
Well, I appreciate you asking that, because there is so much focus on whether or not we should force people to do something. And I think not enough focus on the need to educate people about why they should do it. Strictly from a public health, motivational, and behavior change perspective, it's important to know that we don't have much luck when it comes to trying to force people to do something if we don't couple that with the why. We know that if you force people to do it, they'll do it when you're watching. But then when you aren't watching, they'll stop doing it. We also know that shame doesn't work, and that's true for opioids. That's true for STDs. That's true for HIV testing. What I'm focused on as Surgeon General is helping people understand a couple of things. Number one, COVID-19 has really humbled us in terms of its asymptomatic spread. Really quickly, what that means is that previous diseases like COVID-19, other coronaviruses, really weren't spread by people who didn't have symptoms. You knew if you were sick, and if you were sick, then you were one of those people who was more likely to spread the disease. But up to 50% in many cases of people who are spreading COVID are spreading it before they have symptoms and without ever even knowing they have it. And that's why our recommendations changed to tell people to wear masks or face coverings. The other important thing I want people to know is that masks actually don't inhibit your freedom. They don't inhibit your choice. They enable freedom and enable more choices, because we know that if we can get 90% of people to wear face coverings and get people to practice at least 6 feet of social distancing from their neighbors and practice good hand hygiene, that we can reopen and that we can stay open and we can get back to schools, to worship, to college football in the fall, and to the other things that people want to do. You'll have more choices if you wear a face covering.
There has been some debate and comparisons about, seatbelt enforcement and other things like that. Would you say that those are fair comparisons, and that even if at the state level there should be some level of enforcement?
Well, I'm not opposed to mandates at the state and the local level. We actually support local control and state control. Here's the concern when you talk about enforcement from a federal level, and this is a very practical concern. This isn't subjective. If the difference between a mandate and a guideline is enforcement. And from a federal perspective, we can send in federal troops, and we see that's not working very well in places like Oregon right now, and that there are also concerns about enforcement when you look at what's happened in the African American community and people being killed for very minor offenses. And we also could take away federal funding, which I think is a very tough thing to put on the table at a time when we're fighting a global pandemic. And then there's civil penalties. Again, all of these things work best and become less necessary if implemented at the local level and coupled with education. And so, again, not against a mandate, but really against doing things without making sure people understand why they're doing them, and working with the local communities to make sure everyone understands that we all benefit when people wear face coverings.
Dr. Adams, one of the things that you're really focused on is diversity, and especially looking at how the virus has been disproportionately impacting certain communities. What has been done whether at your office level or generally with the coronavirus task force with addressing these? Because we've been hearing about them, but there hasn't really been any action.
Well, we should be shocked by the statistics. Native American, Alaska Native, and Blacks, 5 times the rate of hospitalizations. Hispanics, 4 times the rate of hospitalizations. And we know that a disproportionate number of the 140,000 people who've died of COVID-19 in this country have been people of color. That should shock us, but it shouldn't surprise us. And what I mean there is we've known for over a century that people of color are disproportionately impacted by an array of diseases, from cancer to heart disease to diabetes and to substance use disorder. And really what COVID-19 has done is shown us those health disparities that have existed in communities of color for all of my life, and have impacted me and my own family personally. So you ask what the task force is doing. We're trying to, number one, improve data collection. And the CDC now collects data according to race and ethnicity. That wasn't happening before, and still isn't happening with a number of other diseases, because it involves a level of coordination that goes beyond the federal government. Again, it may start at the local coroner. It may start at the local hospital where a person is admitted and you need a busy nurse to write something by hand and to fax it in. We're looking at improving those processes to make it easier for people to do the right things. We're doing more research. The National Institute on Minority Health, which is a part of NIH, is doing research regarding how we can make testing more available in communities, and making sure we've got urgent research done to ensure the remedies that are available, like remdesivir, like steroids, like convalescent plasma, work as well and are equally available. And we're also working, and this is critically important for your viewers to understand, we're working with communities to make sure they are participating in vaccine trials, because we want everyone to understand that vaccines are safe and effective, and we want people to feel confident that they're safe and effective in all communities, so that we don't actually worsen disparities with a vaccine, which could happen if the people who are least affected get the vaccine and the people who are most affected from COVID-19 won't get the vaccine or aren't equally helped by it. That's just a small sample.
How do you ensure that, though, when it comes to the clinical trials and making sure, obviously the distribution you can sort of look at, but when it comes to clinical trials, is there any sort of mandate for diversity?
Well, there are guidelines that we have within HHS to really help people understand within the agency that we need to go above and beyond to recruit people into trials. But at the end of the day, you can't compel someone to participate in a clinical trial. We can only be aware of it and have outreach, and that's what we're doing from the HHS point of view. Just today, we released new guidelines from the Office of Civil Rights, helping make sure there was no discrimination, not only within government, but within healthcare facilities according to race and ethnicity. And so these are things that we're doing to try to make sure people understand we recognize the severity and the impact of health disparities, and we're putting meaningful action into place to decrease those disparities. One more real concrete example that I think is important for COVID: we have over 2,000 community-based testing sites, and 70% of the community-based testing sites that are federally supported are with a high social vulnerability index, meaning largely communities of color and places that have risk factors like poverty in those communities. And so we really are trying to direct the resources to the people who are most impacted. There is meaningful change going on, and more funding going to HRSA and to Medicaid, again, which also serve people of color. It is not to say mission accomplished. We are nowhere near where I would like to be as a public health advocate and as a Black man and a Black doctor, but we certainly have moved very quickly on some issues that I've been advocating for my entire public health career.
I know that you're at the top level and seeing all of this change, but I think generally we're still looking at what seems like a repetition of what happened back in March when it comes to a shortage of testing availability, long turnaround times, shortage of reagents and other supplies, as well as protective gear. So while you are seeing this, I don't know that at the general public level, we're actually hearing that. So can you tell us about how that's going to be resolved?
Well, thank you for that. And I think it's important to acknowledge the urgency of now. Over 60,000 cases per day. We do not want this. This is not a good thing. And it's why, again, we're focusing on that prevention message. But it's important for people to understand we are in a very different place than what we were in February and in March in a couple of ways. PPE, personal protective equipment, has increased by over 300%. You are no longer hearing about healthcare workers dressing up in trash bags and having to make do with substandard equipment. It's not that we're where we need to be, but we are in a better place. Remdesivir, steroids, convalescent plasma means that the mortality rate is much lower than what it was back then, that people are getting out of the hospital sooner because of advancements in technology that have occurred. We are, in fact, doing a better job of protecting the vulnerable. The average age of diagnosis has dropped by a decade and a half. We know originally this hit nursing homes and the elderly particularly hard. So we are in a very different place. That's not to say we should pat ourselves on the back, but it is to say people should understand you have a much better chance of surviving if you get COVID-19 right now, and that you have a much lower rate of spread among healthcare workers and other individuals on the front lines, and that we need to continue to do our part to support that effort by wearing a face covering, by washing our hands, by maintaining 6 feet of social distance, and by avoiding large gatherings whenever we can.
really quickly, an update on the task force. A lot of stuff obviously going on behind the scenes, as has been the case. But for the general public to understand, what is the latest in developments? And can you explain a little bit about what attention has been placed on testing, as well as why data was moved from the CDC initially?
Well, the task force is a group of individuals from across government. We have the cabinet secretaries. We have an array of different physicians, myself, Admiral Giroir, Dr. Redfield, Dr. Hahn, Dr. Fauci, Dr. Birx, and we all come together and quite honestly, we hash it out. We put the tough issues on the table, and while we don't always agree, we know we've got the advice of the best people in the country on these issues, really helping us develop policy for what is a novel disease. Again, it's important for folks to remember this disease is still in its infancy. It's barely over 6 months that we even knew that it existed. And when you look at therapeutics, when you look at the change in our stockpile, when you look at an array of factors, we've come a long way in a short amount of time, and we have to continue to keep our foot on the gas because still far too many people are getting affected, far too many people are dying from this disease. You ask what the task force is focused on now. We're focused on communities that are hardest hit. So we know that this disease isn't out of control everywhere. Actually, in most of the country, the disease is under control. There are hot spots. Arizona, for instance, is level or falling if you take out Maricopa County. It's why we sent a CDC team to Maricopa County. I will be going to Miami, Florida. That's another hot spot later this week to make sure everyone on the ground there understands what federal resources are available. We're focused on making sure we're putting out the fires where they exist. And also, again, helping people understand the best tools that we have are really in the hands of the public. It's why I have out my hashtag COVID Stops With Me campaign, urging the public to do their part, because we want to be there to help protect people. We want to be there if people get diagnosed to make sure they get tested, to make sure they get treated. But I don't want you to get tested. I don't want you to have to get COVID in the first place. And you asked about testing, so I'll quickly touch on that. Important for people to know that about 25% of the testing in the country is point of care. That means you're getting your results back in under an hour. Another quarter of testing is done in hospitals, which means you're getting your report back in just a few hours. So only about 50% of testing is done in large commercial labs, and we follow those numbers every single day. And the turnaround time is about 3 to 4 days, which, in my opinion, needs to be improved. The quicker we get that information back, the quicker we can tell someone whether they should isolate or not, and then to do contact tracing. But the fact is, the stories that you're hearing about 2-week turnaround times, I don't deny that that's happening in some places, but the data just doesn't bear out that is what's going on across the board. We're doing over 800,000 tests per day when you look at the numbers for last week. We have improved. We've just got to do a better job of making sure we don't have so many people who need testing and who are getting diagnosed in the first place, because at some point the demand will always outstrip the supply if you have increasing case numbers. We need to drive those case numbers down, and while we're also increasing testing and getting it to the people who need it the most.
Certainly. I'm going to pivot to your health and economic prosperity report in just a second. But before that, I just wanted to get an update on the conversations with the president. Have you had them, and what are they like right now?
So again, the task force meets multiple times a week as the larger task force, and subgroups meet throughout the week. So every single day, people on the task force are working to make sure we're improving guidelines, that we're tracking data, that we're doing outreach to communities. As a matter of fact, before speaking with you, I was just on a call with a large number of community stakeholders from across the nation talking about ways we could address disparities in COVID-19 outcomes. That information from the task force goes directly to the vice president. He's at every single task force meeting, and then the president is briefed by the vice president every single day. And the president occasionally comes down. He's a busy man. He's working on a number of different things, comes down and participates in the task force directly. So the bottom line is the president is getting information from the task force every single day, and it's a process that we're constantly trying to improve. But I've got to tell you, when I sit at the task force meetings, I'm surrounded by the best scientists in the entire nation. Dr. Francis Collins, Dr. Deb Burks, Dr. Tony Fauci. And again, that input is being given to the President of the United States, and that's all that I can ask for. And I want the American people to know that I and the other physicians are doing everything we can to make sure we're providing good and sound advice.
And this report that you've made as such a priority, I know that generally speaking, there's been sort of this patchwork approach and sort of independent organizations or independent communities really taking it on themselves to address these health disparities. What is it you're looking for? I know that there's already been HHS support for that Morehouse School of Medicine project, but where else do we go from here, and what are you looking to achieve?
Well, we know that the U.S. spends more money on healthcare than any other developed nation, westernized country, and gets actually some pretty poor results for their investments. This is what we call the U.S. health disadvantage. We know that this U.S. health disadvantage is actually hurting not just our own health, it's hurting our economic competitiveness. The number 2 cost for most Fortune 500 companies behind salary is healthcare. We know that poor health also impacts whether or not people show up to work and how productive they are while they're at work. It impacts workplace accidents. It impacts the ability to recruit a healthy workforce. We know that in many places that were hard hit by the opioid epidemic, they can't staff factories because they can't find enough people who can pass a drug test. This is the U.S. health disadvantage. And what really concerns me, and this report started well before COVID-19, but COVID-19 has shown a magnifying glass on the problems that exist here, that in many cases, health is pitted against economics. And we've seen this happen with COVID. If people want to say you either are for reopening or you're for keeping people healthy, I want folks to understand that these two can't be delinked from one another. And what we're doing is really working with the Chamber of Commerce, the Business Roundtable, working with UVA's Darden School of Business, working with business leaders to help them understand that when businesses invest in the health of their communities, they see not just health metrics improve, but they see business metrics improve. Again, people are more likely to be at work. They're more likely to be productive. These businesses become employers of destination for younger folks who are looking for places to move their family to. And if we can do that, then we can actually get more people on board with creating the environment that allows everyone to make healthy choices and puts everyone in the best possible position to live a long and healthy life. And we will lessen disparities because personal responsibility is critical, but the choices people make are 100% dependent on the choices they have around them. And far too many people, especially people of color, don't have the opportunities, the choices in front of them to be able to make an appropriately healthy choice for them and their families.
Thank you, Dr. Adams. And one final quick round question for you. There's been a lot of discussion on between medical experts about there being a lack of a federal response. Are you under the impression that there's a lack of a unified federal response to the outbreak?
Honestly, nothing could be further than the truth. I'm working 24/7 and all the other doctors are working 24/7 to coordinate a federal response. I used to run a state Department of Health for 3 years. It's important for people to understand that you can't do everything from Washington, D.C., that the majority of the work and the majority of the authority is at the state and local level within the public health systems. And so what we're doing is working closely with state and local health departments. Again, I'll be going down to Miami, Florida soon after this to meet with the Surgeon General of Florida and to meet with the governor. I was in Georgia a few weeks ago meeting with their health commissioner and with their governor. We have weekly calls with the governors. We are really trying to have a federally supported, state-led, and locally executed response. And that's the way public health works in this country. And that can be frustrating for some people, but it's also where we get a lot of great innovation from, because we know what works in Billings, Montana isn't what's going to work in downtown New York City. We really need to give the flexibility for local response, but we need to make sure there's federal guidelines, which we offer, and federal support, which comes from Congress, to make sure those state-led and locally executed responses are a success. And that's what we're trying to figure out and push with the task force. And again, while I would by no means say mission accomplished or say that this has been a success, I would say that I'm proud of the work that the CDC has done, that the members of the task force have done, that NIH has done, that the federal government is doing to put us in a position to be able to defeat this disease. And I think that we can defeat this disease if we can get the public to do their part, and we can get state governments and local governments and the federal government to all work together. And I'm seeing more and more of that.
Dr. Jerome Adams, U.S. Surgeon General, thank you so much for your time.
Thank you. COVID stops with us, and we can do this. I'm 100% confident we can defeat this disease. We know that in just the course of a couple of weeks to months, Italy went from being one of the hardest hit in the world to actually now being open for tourism and having schools open again. We can be there too if we just all do our part, put the politics aside, and actually do what it takes to overcome this pandemic.
Bill Gates made his name and fortune at Microsoft, but over more than 25 years in philanthropy, he became a leader in the worldwide fight against disease. Then the pandemic hit. Ever since, he has worked at the center of the global response, coordinating solutions with health officials and drug developers, and donating more than $350 million with his wife Melinda through the Bill and Melinda Gates Foundation. Since it launched in 2000, the foundation has donated more than $50 billion to reducing poverty, advancing medical research, and expanding access to life-saving drugs. In this episode of Influencers, Bill Gates is here to talk about how long it will take to contain the virus and what it means for the economic recovery and whether life will ever get back to normal. Hello, everyone. I'm Andy Serwer, and welcome to Influencers, and welcome to our guest, Bill Gates, co-chair of the Bill and Melinda Gates Foundation and co-founder and former CEO of Microsoft. Bill, great to see you.
Great to talk with you.
So it's been about 4 months now, Bill, since coronavirus was widely recognized as spreading throughout the United States. We're still seeing cases increase in half of the states here. How would you assess where we are right now fighting the coronavirus?
Well, this has been a huge tragedy. The health costs, the economic costs are, so gigantic, hundreds of thousands of lives, trillions of dollars. And so we need to stop this thing. We need to stop it in the United States. We need to stop it globally. The only positive thing out of this is that the pace of innovation, the way our foundation is working with the private sector to create therapeutics and vaccines, that's moving at record speed. And that's what gives us hope that we can get the death rate down with better therapeutics. Even by the end of the year, many new therapeutics will be out. And then during 2021, we should be able to manufacture a lot of vaccines, and that vaccine, key goal is to stop the transmission, to get the immunity levels up so that you get almost no infection going on whatsoever.
Yeah, you predicted recently that this current surge in the coronavirus will drive up the death rate. How bad do you think things will get, and when do you think that would turn around?
Our peak death rate was well over 2,000 a day. The doctors have learned to use the ventilator less, to use oxygen earlier. You have remdesivir, that's an antiviral from Gilead. We're trying to get that to be reformulated so it's even easier to use. You have dexamethasone, which is an immune system modulator that a study we funded in the UK has shown. So there's the risk of death has gone down almost a factor of 2 because of these treatment understandings. But as we get into the fall and people are more indoors, if we haven't cut the infection going into that, we could get back up to that 2,000 a day.
You've said that serious mistakes were made in handling this virus, this pandemic here in the United States. What was the biggest mistake?
Well, even today, people talk about the testing number, but people should know how incompetent it is that
we reimburse for a test where you don't get the results within 24 hours. You need to prioritize the tests so that you're getting the results back. You shouldn't reimburse at all for a delayed test. So the US is more blind to who should be quarantining themselves than any country in the world. And it's ironic because we have more of these PCR machines, we spend more money on them, and yet because the CDC wasn't allowed to prioritize who gets tested, and the states have a hard time doing that, we are allowing the majority of tests to be essentially wasted. That delay, where they made it harder for the commercial providers to get their tests approved, they didn't let them do the testing, they didn't do community testing, those March mistakes led to that first gigantic problem that we had. And in contrast, people like South Korea got to the commercial test providers and were able to have a very modest epidemic.
If you were in charge right now, Bill, maybe even the President of the United States, what would you do?
Well, trying to denigrate Dr. Fauci probably isn't the best approach. You want the experts to get the airtime, let them talk about, what drug trials have worked, which ones haven't. Don't, mislead people on those things. And, the US CDC is a very capable organization, the best in the world. Dr. Fauci and I talk on a regular basis about this innovation pipeline and how our foundation and NIH are funding both a first wave of vaccines and then a second wave of vaccines. And so the capacity to do this right exists in the country. You just build a website, put the CDC's name on it, and it will prioritize who should get tested. You get the message about masks to be a, kind of bipartisan, let's protect other people type message. And then you engage in the complex discussion about which things it's beneficial to reopen, like, perhaps kids under 15, whereas, schools for older kids in communities with lots of infection, sadly, you probably aren't going to be able to do in person.
You mentioned masks. Should masks be nationally mandated, Bill?
Well, the downside to wearing a mask is so low that, I can't understand why, it's even a controversy at all. The mask is cheap, it's easy to wear, it has no negative effects. If you're going outside your house, you put on a mask because you'll end up getting close to people. And we know this is not a coughing disease, just talking can expel the virus.
Do you think about things like the bills in Congress in terms of the relief, the stimulus package? Or is that kind of the stuff that you weigh in on, or have you thought about how that should go?
Well, the expertise of our foundation is more around the disease tools themselves. And so, yes, there are elements of these supplemental allocations that are very, very important to us. How we fund the therapeutics and the vaccines, including not just the United States. We're trying to get 1% of the bill that's under discussion now to go to buy vaccines for the developing countries, because not only would that save lives and have this great humanitarian and strategic benefit in terms of U.S. leadership, it's also the only thing that will stop the disease from coming back to our country. And so the idea that 1%, shows that the U.S. cares. Yes, we funded a lot of R&D, but we haven't funded the procurement for these poor countries, which historically in every global health thing, whether it's smallpox or polio or HIV or Ebola, the U.S. is there not just in a selfish way, funding its own factories, but also helping out the entire world. And so that's a very compelling case. And so I am every day talking to people in government, people at drug companies, trying to make sure that we get money for the entire world.
Let's drill down to that a little bit. I mean, how would you prioritize then who gets the vaccine? And let's just say you've got Moderna over here. We were talking about J&J. If we're lucky, there'll be a couple of them, maybe 8 months, 9 months from now. Do you prioritize things in the United States by risk group? And then how do you disseminate globally, Bill?
Well, the only solution to this constrained supply is to have massive manufacturing capability. I mean, if you're going to vaccinate 80% of the planet with 2 doses that may be necessary, that's over 10 billion doses of a vaccine. And to make that even in, say in a year, that would be 20 times more than any vaccine production ever. And so what we're looking at is no matter who invents the vaccine, say AstraZeneca or Johnson & Johnson, where there are other factories around the world that could be brought up to speed to make that. So, get factories in India, factories in Europe, not just the ones that the US has been involved with that are in the United States. And so the companies that are doing this, with the global mindset and who say, okay, we're not trying to profit on this, they're engaging with us on this whole production plan. Even so, you will have shortages, but we're able to fund those factories at risk because we can move very, very quickly. And so that I feel good that those plans are coming into place. We'll want to go for health workers first. Anybody who has to mix around people who work at nursing homes. The vaccine has 2 good things. One is it should prevent transmission, and the other is it should prevent you from getting sick. And understanding exactly how well any of these vaccine constructs do that, that's what we're trialing. The first vaccine that gets approved may only be 50% effective. And so we'll still need to go, we need eventually to get one that's cheap, high volume, and about 90% effective.
Should the pharma companies be able to profit off of this, Bill?
Well, if you've taken money from, U.S. BARDA or others, hopefully they put terms in those contracts so that the pricing is reasonable. There are 1 or 2 companies that have, like Pfizer, who've chosen to fund it themselves. And so they put out the R&D and they did a purchase option for the U.S. So it's a little different in that case. Definitely for the poorest countries in the world, always for medicines, they should get just the marginal cost of manufacture, no matter whose it is. So in the case of the developing countries, nobody should try and make money. That would make pharma look really bad. I'm hoping that the great innovative skills that pharma's showing here, that they behave in a way that their reputation is better after the pandemic than it is going in.
Bill, for those people who don't know, could you explain a little bit about exactly how the foundation has been working to fight coronavirus?
Yeah, so a lot of the expertise on how you deal with infectious disease that is not in the private sector is at our foundation because, malaria, HIV, tuberculosis, these huge killers that are only modestly in the rich countries now, but are still a main reason why people die in the developing countries. That's our regular activity. And so, understanding vaccine costs and factories and trials, is our deep expertise. And we spend billions of dollars a year working on these new tools. When this respiratory disease caused by coronavirus came along, we shifted our activities to focus on this because it's hurting the health systems everywhere, and so we're working on therapeutics, we're working on the vaccines. It's because we're not going to use the marketplace here. It's an imperative to accelerate this research, even not based on how much money people are going to make, our ability to evaluate which vaccine looks promising and tell countries, okay, please fund this factory. We're kind of in a central role in terms of the depth that we understand the biology and these new tools.
Have you ever given any thought to the fact that you're the person, maybe one of the people, but certainly a key person who recognized early on the power of the PC and the PC revolution, and you're also one of the people who recognized how devastating these pandemics could be? Have you ever thought about that? And is there any connection between those two massive epiphanies, perhaps?
Well, my career has been about innovation, and Melinda and I picked global health as the biggest single thing the foundation works on, and that gave me the exposure to say, wow, respiratory diseases, human-to-human transmitted, when people are traveling around so much, could be worse than 100 years ago when we had the big flu pandemic. So I spoke out about that. I wish I had been wrong. This is nothing but bad. This is not like I told you so type thing, because we could have taken the warning from myself and other health experts and been better prepared and avoided 90% of this damage. So the only good thing here is that we will prepare for the next one. That is the ability to scale up diagnostics and therapeutics and vaccines. We will get that right. And the science, which is what always draws me in, whether it's computer software or biology, the science is improving so quickly that by backing the right teams, being willing to take risk, we will come out with a set of tools to make sure this doesn't happen again.
You're so engaged. I mean, did you ever think about becoming a scientist or a doctor when you were younger?
Well, I love all of science. And in my Microsoft days, I was so engaged in running Microsoft that I didn't get to stay up to date on what was going on with genetics or a lot of the other sciences. Since I retired in 2008, I've been able to look broadly. And of course, the foundation work gives me access to some incredibly bright people and teams that we come back. We're doing, just phenomenal work with the goal of saving lives. So, I've gotten to have two super interesting careers that are, 80% alike in terms of working with innovators and looking out into the future in terms of what can have a dramatic impact.
You mentioned talking to all kinds of high-profile people, great minds, et cetera. I know you talked to Warren Buffett a fair amount. What do you guys talk about when it comes to COVID-19 and the current situation, Bill?
Yeah, actually, Warren and I are talking on a more regular basis than ever because the policy issues, the economic issues, what this means for various companies. Just talking with Warren about, okay, furniture sales are actually at a record high, but, railroad shipments are 20% below their peak. The economic situation, overall, it's pretty tough, but it's complex to say, okay, which kind of businesses will survive? Why is the stock market, at the level that it's at? Why are interest rates where they are? And so Warren and I find the world fascinating, and there's, a lot going on that we're trying to puzzle out. Okay, what can we do to help, or where is this headed?
He told me in March, Bill, that you said to him that you were not sure that the summer would make this virus go away. And you were right, it seems. Why did you think that?
Well, the U.S. opened up while infection rates were still going up. The summer is helpful. High temperature reduces force of infection. People spend more time outdoors. The fall, if we didn't have these new innovations coming, or more people adhering to the face mask regulations, the fall could be very tough. And part of the irony is that it's the communities that haven't had it badly who are going to be most at risk in the fall. And, so we saw in the spring a lot of cities were saying, well, we're not New York. And then, even as that rate was creeping up, they opened up. So, the U.S. Sadly is not taking this seriously. The fall could be tough, mostly in new places. And then, of course, we have the entire world where there's a lot of places. South America's tough today, but Africa, the numbers keep going up. Thank goodness that we have the innovation coming, because otherwise the eventual damage, would go on for over 5 years.
Yeah, and one place we need help still is testing. I mean, Quest just this week said they're actually falling behind or not catching up to that lag that you spoke of. Why is that? What can we do there quickly?
Well, it's insane. You shouldn't pay anyone for a test where you have the results that it takes longer than 48 hours. The whole point of the test is to let you know that you need to isolate yourself so you don't infect other people. Once you test positive, your days of infection are actually, unfortunately, a few days probably before you go to get tested, and then that 3 or 4 days afterwards. And so there is zero value to a delayed test. You can write an apology note to all the people you saw during that time, but the idea that we're not at the federal level outraged by the waste of money and the inequitable allocation of our testing, which is the simplest thing about this whole thing. We have more PCR machines than any country in the world. And, to get the supplies, get the prioritization, we've shown now that you can use a swab that you just put at the tip of the nose. And, we got the FDA to approve it. There's still a lot of places using that one where they, the worker who has to get exposed jams it into the back of your throat. So it's been so slow. The conversations with, CDC, they say, hey, that's up at the White House level. And then you don't have the experts there being listened to.
17 players and staff of Major League Baseball's Miami Marlins have tested positive for COVID-19 in recent days. Should the league suspend or shut down the season even?
Well, I'm not an expert on that. I'm the one area I'm really trying to make sure that the data is available has to do with the choices people make on schools. The idea that they're not going to have fans, all these sports are trying to do things in a safe way. And, I don't know what trade-offs are involved there. The worst thing about infection is if it gets to elderly people. And so anyone, if you're in a multi-generational household or you really have to behave in a way that you're not connecting to the elderly, which is why the death rate's gone up over the last few months, because so many young people got infected and then it spread up in age.
But is it fair, do you think, that we're testing all these pro athletes while tests are so hard to come by in the rest of the country?
It shouldn't. If we would just use our testing capacity properly, that would be okay. And the testing capacity will go up. There's a lot of new machines. There's a test called the lateral flow test that some people will be coming out with. So we're working with a lot of people, including getting that swab out in the community. So you can just go to a community center or the pharmacy and get that swab and give yourself the test and then put it in the plastic bag and send it in. That avoids the delay of, getting the test sent to you or having to drive somewhere or go to the doctor's office where you might expose somebody. So the innovation on the testing side, there's a roadmap there, but it's been slow to get attention.
But what about these conspiracy theories? And you're the subject of them, that you've used this pandemic to attempt to implant tracking devices in people. Does it bother you that this stuff is out there, particularly when you're working so hard to eradicate COVID-19?
Well, certainly it looks like conspiracy theories, these lies travel faster than the truth, particularly in an age of social media. The fact that our foundation is involved in vaccines and it has to do with saving lives, that's true. They just invert it to say that somehow, we're not trying to save lives. Instead of giving money, we're trying to make money. And, it's unfortunate, particularly if it means people are reluctant to take the vaccine, if it means they don't trust this message about face masks because they think that people giving them advice are, corrupt in some way. I mean, the two most attacked people in this phase have been myself and Dr. Fauci. And, Dr. Fauci's just telling us the truth. Some days he's allowed to tell the truth. Some days he doesn't get contradicted, by his leadership. So this is a communications exercise. And so far, the U.S. doesn't get a very high grade. And that could mean that, seeking out therapies or willingness to use the vaccine will make this disease last longer.
I mean, you're seeing this stuff on social media. Just this week, there's a video by people who are purportedly doctors saying that you shouldn't wear masks and suggesting you use hydroxychloroquine. And it got just tons of views on Facebook and YouTube. Should these companies be taken to task for that? I mean, should they continue, for instance, to get protection by Section 230?
Yeah, the changing 230, I don't think people have thought through what that leads to. But
are you against that then?
Well, the idea of trying to create liability for any untrue thing, you have to decide, would you still be able to have that type of forum? In terms of this outrageous, hydroxychloroquine anti-mask thing, it spread so fast that even though eventually the social media people stopped it, it was so famous that now people are still seeking it out. And, so their ability to stop things before they become widespread, I think they probably should improve that. I don't think it's easy because it spread so quickly. I mean, that thing was fairly new, and now we have 14 million views, and you can't find it directly on those services, but everybody's sending the link around because it's still out there on the internet. And that one is, this hydroxychloroquine thing, this is nutty stuff. I mean, we're supposed to be a developed country that, uses science. Oh my God, it is really hard to believe that that's what's being retweeted.
Are you frustrated by Tony Fauci's his boss's leadership? And I think you've been reluctant to criticize President Trump by name, and why is that?
Anything that encourages the executive branch to come around as opposed to, pugilistically fight back. We're all in this together. People of both parties are sick and dying and being hurt economically. So, and we have, everybody involved has made mistakes. We didn't know that masks were such a big deal. Our foundation didn't, Dr. Fauci didn't. In fact, in the early days, we wanted to save the mask capacity for the health workers. And so it's fair to say that was an honest mistake. We actually understand why hydroxychloroquine in the test tube looked effective, but the cells that were used are not the same as human cells. So that's why that got so confused, and so now, we're pursuing other things, and there's lots of good therapeutics that will work, that are coming along. And, so we want to not push away the leadership that, should enable the positive truth to get out. So just, making a fight out of it, I give Dr. Fauci a lot of credit. He just rolls with the punches and, tries to get it out. We touch base with him on a regular basis because the U.S. government, our foundation, are the two biggest funders of these new interventions. And that is the hopeful part of this whole thing, that actually that's the one thing the U.S. has been the best at. Other governments aren't funding research and development on new tools at the same way the U.S. is. Now we're encouraging them to do so, but they've been a bit slower.
Bill, Google just announced that they wouldn't be having people back to the offices until next July. Is this going to really change the way we think of office work forever, for a long time? What's your take on that?
Yeah, there's a lot of debate about that. I am surprised that nobody's gone into our foundation offices since early March. Microsoft's offices, which are this huge campus, are empty, and yet for certain types of work, the productivity is not dramatically reduced. Now, I don't think we'll stay at that extreme. We want you to meet new employees and sit and talk with each other, but do you need to come in 5 days a week for a full day? I think people's minds have been opened about less travel, maybe less time in the office, setting your home up so you have a space that you're not interfering with the other members of the household, so you can concentrate. I think that will be quite different. How far different companies will go, is open-ended. But yes, it's now possible to do a lot of jobs remotely. A lot of those employees are going to move to some part of the country, because they know not until July are they expected to show up.
Last question, Bill. You talk to all kinds of people. Who gives you the most hope that we're going to be able to get out of this at some point? You mentioned Tony Fauci. What other people do you find inspiring or just are doing great work?
Well, the private sector companies, a lot of them have diverted their talent onto this work. And that's fantastic. A group we work with at Oxford, Adrian Hill and his team, they, are contributing to this. Trevor Mundell runs our global health stuff, and, he's just day and night, trying to accelerate the work here. It's great to see these teams coming together. And it's almost kind of a warlike situation where you think, hey, time is of an essence. Anyone we call, is likely to respond. We need your expertise on how to make antibodies quickly. We need more glass vials, for 6 billion vaccines. That all these deep capacities being used where it's not, a profit-driven thing. I'm quite impressed with that. There'll be a great story to tell. Not everybody's participating perfectly, but the private sector overall, and the boundary between academia and the private sector and the speed now, it's really wonderful. And, that's where we're going to get some great tools, even a few well before the end of the year.
Oh, that's great to hear. That's great to hear. All right, we're going to leave it at that. Bill Gates, thank you very much for your time.
Yeah, great talking to you.
You've been watching Influencers. I'm Andy Serwer. We'll see you next time.
Joining me now is Dr. Robert Redfield, Director of the Centers for Disease Control and Prevention. Dr. Redfield, good morning. Thank you so much for joining me today.
Thanks for having me.
Obviously, we have to touch on the news of the day, which is the CDC taking action on evictions and the moratorium on them. As we're seeing this pandemic continue to affect Americans, explain the thought process on why the CDC was able to take action while we're waiting for Congress to sort of make more progress on something like this.
Well, I think the importance to recognize that homelessness is an important risk for COVID transmission. And the opportunity to try to prevent individuals from losing their stable housing, where they would either go into concongruent housing with other individuals and therefore put at risk potential for further COVID spread, or tragically could actually become homeless. And so using our public health authority, seeing this as a public health risk, we're part of the president's executive order that wanted to try to interrupt evictions at this period of time. So for the next 4 months, there's an interruption of evictions for individuals that make less than $99,000 annually, or a couple greater than, I think, $198,000.
Could the CDC extend this if nothing happens in Congress in December, by December?
It's conceptual. It could be extended. Obviously, we're doing this in partnership under our public health authority with HUD to make sure that we try to minimize the disruption that may be caused by an increase in homelessness.
And clearly having people, cramped together in spaces is something that is continuously a struggle for the country, and something that I'm sure you're focusing on. And, after Memorial Day, you mentioned that we saw a spike in cases within that 2-week period. Labor Day is coming up. What are the concerns there?
I think it's really important because we did, in fact, see the Memorial Week surge, and then we saw a surge after 4th of July. We're actually doing very well now. We're improving. The cases are coming down substantially. We've had probably close to a 40% decline in cases from the time we were peaked in late July, and deaths are coming down. We want to keep that trend. Clearly now with Memorial Day, we don't want it to become a spreading event. So we're really appealing to everyone to be vigilant about wearing a mask, to be vigilant about social distancing, to be vigilant about hand washing, to be smart about crowds and really limiting any crowding that they would do. Stay away, obviously, from crowded bars for any crowded spreading event. And the other thing I'm advocating people do or really reflect on this Memorial Day weekend is to talk in their families about the importance of getting the flu vaccine. The flu vaccine is now available. Flu season's about to start. So it is really important. I don't think you can stress enough on your news outlet how important it is to take serious Labor Day and to be really vigilant about the mitigation recommendations that we have. And let's make sure that Labor Day is not a spreading event. If it keeps with the downward trend, we'll be in a strong position as we enter October when the flu season really gets started. But if we have a spreading event right now, with Labor Day, then 3-4 weeks later, we're going to have that surge of new cases, and it will be much more complicated. So really appealing to the American public to let's be extremely serious this Labor Day about embracing the mask, the hand washing, the social distancing, avoiding crowds, and I would argue make a family commitment to get the flu vaccine.
Worst case scenario, if we do in fact end up with another surge prior to the flu season starting, what are the sort of strategies that you've had in place or that are being developed to help so that we don't have a repeat of what happened earlier this year?
Well, I think that's the real challenge. I mean, that's the real challenge, Angela. I mean, I think that I've said in the past that this could be one of the most difficult public health winters we've ever had with the convergence of flu and COVID. However, if we're really vigilant about these mitigation steps, we're seeing the summer transmission of flu right now, because we do get flu all year round, but flu over the summer late spring and summer is the lowest level we've ever seen. So it means that these mitigation steps that we're using for COVID are also impacting flu. But if we do have a lack of mitigation and we do have a surge of COVID, you can see that if we have that surge now, it will end up peaking 4 to 6 weeks from now. That's the same time we're going to start to see flu. So again, I think all I can do is really appeal to the important power that each of the people in our nation have to become part of the solution by embracing these important mitigation steps.
One of the other things, obviously, that's a conflating issue is school reopenings. And we've seen already college campuses having to reverse reopenings and move to distance learning, as well as other schools. Your thoughts on that and what we can do right now, and how the schools can, in fact, tackle this? I know there are some areas where school is in progress, especially for younger kids.
Yeah, first I want to say reopening schools K through 12. I've said it before, I'll say it again. I think it is a critical public health decision that the public health of the K through 12s are best served by getting back to face-to-face learning. So we really do need to make a commitment to figure out how to get these schools open safely and sensibly, obviously understanding in the process of protecting the vulnerable. And many school districts now are reopening just that way, safely and sensibly. Second thing I want to say is the risk of infection, COVID in schools, particularly now K through 12, that risk actually, those students don't get the COVID in schools, they get the COVID in their community. So the best thing we can do to help prevent COVID in schools is to control the COVID in the community, which comes back to all of us doing these mitigations. College campuses, very important. First, we have the fastest growing number of cases, if you do age demographics, is that group between 15 and 30. We need to appeal to that group to really listen to that fourth statement that I said, avoid crowds, right? Be smart about crowds, wear your mask, social distance, wash your hands, and be smart about crowds, because a lot of these crowding situations, these parties and these gatherings are really becoming super spreading events. We want to really appeal to individuals that have COVID, obviously, to self-isolate. We do want college campuses to really reflect on their decisions when they do have these outbreaks. We don't believe it's in the interest of our nation to have those students sent home and then reseed all different parts of our nation. We think the students should be able to be isolated on campus. Many campuses have got isolation dorms until there's recovery, and then to try to really stress and enforce the importance of their student body, that this is a chance for them to contribute to America's effort to win the war against COVID by, let's forgo the parties for now. Let's forgo the mass gatherings. Let's all act socially responsible for our fellow schoolmates and for our nation.
I know that one of the things everyone is waiting with bated breath for is a vaccine, and I know that there are antibody treatments in the works in the interim. But with the draft of the National Academies out yesterday on distribution, I'm curious on your thoughts on sort of, first of all, what they've said in terms of the grouping and the priority. Does it align with the strategy that you, or in general, Operation Warp Speed and the task force have looked at?
Well, thank you. This is obviously a work in progress. The National Academies come out with their initial recommendations that really highlighted the four kind of areas that they focus on: the risk of acquiring infection, the risk of morbidity and mortality, the risk of negative impact on societal factors, and of course the risk of transmission of the disease and infection. And so they've proposed a multi-phased approach. It's out now for public comment, and it will go through that process and then come back and they'll issue a final report. That final report will be a component, because ultimately the decision is the decision of the Advisory Committee on Immunization Practices, which is also an independent committee that has credibility in this space for decades, making recommendations on how to use vaccines across the nation. And they will take the National Academy's thoughts under consideration along with their own deliberation, and they'll finally make a recommendation to how they believe is the best way to begin to distribute this virus, this vaccine, in an equitable way to make sure the allocation's equitable across this nation.
Certainly don't want to be spreading the virus there. On the point of the hospital workers, I think there's one thing that I've had a lot of discussions about within the healthcare community, and that is hospitals employ a lot of people. And so when you're talking about, frontline workers receiving and being part of that initial priority, that includes a wide array of people, not just those who are wearing lab coats or white coats and stethoscopes, but those who are maintaining the facilities and work within them. Any thoughts on whether or not those individuals would in fact be included?
Yeah, I think this has to be, again, part of the considerations, but I would echo what you said. When we look at risks to healthcare workers and we broaden that understanding, people that help the health system work, for example, in nursing homes, the risk of infection was not greatest in doctors or nurses or respiratory therapists. It was the greatest in nursing aides, right? So just to echo that in hospitals, that, when we look at the broader issue, it's going to be really an understanding who's at greater risk of infection and how would they benefit that. And again, to try to make those initial allocations in an equitable way that really sets around the priorities. And the major priorities will be obviously risk of infection and risk of bad outcome from infection, and how that gets sorted out in the final recommendations. I have confidence in the Advisory Committee of Immunization Practices. They've already had several meetings. They will be making these decisions based on real data of the vaccines, how they perform, where we know that they're going to be able to be effective and safe. And I suspect it's really going to be those two groups, the individuals greater risk for infection because of their employment, and the individuals at greater risk for bad outcome if they happen to get infected will be the initial groups.
Sure. Looking at all of the changes sort of that the country has gone through, each individual has, personally been affected and changed a lot of their lifestyle. How have you handled, the outbreak, and what changes have you had to make? I know you've also, had to fly to different locations and other things. So what has the experience been for you?
Well, part of it is I'm kind of jealous of my clinical colleagues because my whole life I'm really a doctor. I practice medicine. And I grew up practicing medicine, taking care of men and women that were trying to confront and live with HIV infection. And I went through some pretty tough times where most of my patients, unfortunately, died in the prime of their lives. So I really miss that practice of medicine. And I really want to applaud the men and women that make the health system work in this nation. It's that same sense of vocational commitment, though, that I want to applaud the teachers now that are stepping up to open up these schools so that the K through 12s can get back to school. So that's first and foremost. I've tried to say one of the focuses of CDC is to make sure that all of the important efforts that we're doing, trying to end the AIDS epidemic by 2030, combat, teenage nicotine addiction, going after drug use disorder to make progress, confronting maternal mortality. I've told the team, we can't let those public health objective goals go on the sidelines here, that we have to keep those moving forward right now to make, progress. So 700 women die in this country a year just giving birth to a baby. We have to really continue those efforts and make sure that we don't have that. So, I continue to be optimistic that we're going to come out of this stronger, with a stronger public health system in this nation. Clearly, that's one of the areas that I think people opened their eyes to, that we have underinvested in public health in this nation for far too long, for probably over 50 years. And, it's time to make that investment in data modernization, laboratory resilience, public health workforce, in our global health security footprint around the world, so that we're well prepared to confront the pandemics like this. Right now, I will say we're preparing earnestly for what I anticipate will be reality, is that there'll be one or more vaccines available for us in November, December, and we have to figure out how to make sure they're distributed in a fair and equitable way across the country. I will say the first couple years at CDC, it was the time of my life. I love science, I love data, I love service. I'm surrounded by over 20,000 men and women that are trying to use their skills to improve the human condition day after day, and I saw progress. I will say the last 9 months, I'm in the middle of war, because this is a real battle. This is one of the most critical, complicated public health crises that this nation has faced in over a century, and to extend it the world. And to sort of be in the middle of that, it's a big effort. I mean, it's an honor, but I sure liked the first 2 years a lot more, because I was seeing meaningful progress in making meaningful improvements in a variety of areas, all the way from one end, from drug use disorder, all the way to another area, that ending the AIDS epidemic, fighting an Ebola outbreak. I'm on my third Ebola outbreak now in the Congo since I've been CDC director, taking on the increase in nicotine use among high school and middle school and elementary school thing, and trying to reverse that, going after maternal mortality, trying to make meaningful programs to confront health disparity. I mean, every day was kind of fun, because I was trying to divide my energy and encouraging different really talented people to accelerate their efforts to improve the human condition. In the last 8 months, it's been very focused on helping this nation confront the war that we're fighting against this pandemic. And I'll close.
It's been really a significant change for you, I'm sure, just in daily operations.
Big change.
And there's been a lot of political sort of back and forth as well. I'm curious about the World Health Organization and other bodies globally. Has the political tension affected your ability to work with colleagues overseas?
No, it hasn't myself. I think in general, people see CDC for what it is. It really is the premier public health agency in the world. And we're really focused on that, is how to use data and science to improve the human condition, stay focused on that lane. I do have to, try to encourage my colleagues, because they're really outstanding men and women that work at CDC, not to get distracted by the critics. Sometimes I wish the critics would understand that they do have the potential to suck energy out of people that are trying to do the right thing for the right reasons. So the criticism is not always benign. It can actually change the enthusiasm, the earnest. And so I think the hardest thing and the most important thing that I do as a director now is remind the men and women how important they are, how valuable they are, how their work is valued, and how they have to stay focused on, if we'll say, focused on the goal line, and not get by some article in the newspaper or some criticism on one of the news shows. That, this is an agency that's not used to having negative criticism. So, but I will say that we've worked, earnestly. When I got the first models back in late February, early March, it was a very difficult time for me, because those models by very smart people in my agency told me that they anticipated 1 million to 2.4 million people would die of COVID before October 2020. That was catastrophic if you start to think about that. I think we all committed to do all we can to try to save human life. It's always hard to prove what didn't happen, but I do believe that the efforts that have been made over the last 8-9 months have had an enormous impact on saving human life in this nation.
Certainly hope that we can continue that trend going forward. Dr. Robert Redfield, Director of the CDC, thank you so much for your time today.
Thank you very much. It was a pleasure to be with you.
I'm Anjali Kimlani, senior reporter here, covering all things healthcare, which means everything COVID as well. And that gives me the responsibility and the pleasure to introduce you to someone who needs no introduction, Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases. Dr. Fauci, thank you so much for joining us today.
Good to be with you. Thank you for having me.
I'd like to start off with a debate I'd like you to settle for me, please, and that is, right now we're looking at skyrocketing cases across the country, setting daily records at more than 80,000 cases per day. People are saying that this is a third wave, but I seem to have missed that. So I'd like for you to settle this for me. We're in the third peak, clearly. What wave are we in? Is this an elongated first, a second, a third? Please.
I look at it more as an elongated and exacerbation of the original first wave. If you look at when we got hit badly, which was dominated early on by the northeastern corridor, particularly the New York metropolitan area, the cases went way up and then came back down to a baseline of about 20,000 cases. So we never really cleared and got down to a very low baseline, which I would consider to be less than 10,000 per day, maybe just a couple of thousand per day. So we stayed at 20. Then you remember when we tried to, quote, open up the economy again and open up the country, there were several states that did that in a somewhat varied way. Some did not adhere very well to the proposed guidelines. And what you saw, particularly along the southern states, Florida, Georgia, Texas, Southern California, Arizona, we started to see a peak that brought us up to around 70,000 per day. Then it came back down again only to about 30 to 40,000 and was stuck at around 40,000 for several weeks to, if not a month or more. And now as we're getting into the cold weather, we came back up again to the worst that we've ever had, which was over 80,000 per day. So if you look at the chart, which you just showed, we've never really had waves in the sense of up and then down to a good baseline. It's been up and wavering up and down till now we're at the highest baseline we've ever been, which is really quite precarious. So, it's kind of semantics. You want to call it the third wave or an extended first wave. No matter how you look at it, it's not good news.
That's a very sobering, and thank you for settling that. We look at, you for guidance for all of what is going on and the advice that you've given, the mitigation strategies. And it seems like you've been able to really get that message out there and directed it to a number of very segmented audiences. We've seen just how insulated some populations are in this country as a result of this pandemic. How do you decide to, take on some of the media requests when it comes to, shows with celebrities or children's shows? I've seen you on a couple of these and you make all the time for it, but what goes into that decision of targeting these specific groups?
Well, I try, and my colleagues also. I believe that public communication, when you're in the middle of as serious a situation as we are now with this historic pandemic, is absolutely essential. And you try to get to various segments of society. So, I think you brought up a good point. I've done things where you appeal to children to try to get them to understand without frightening them the crisis that we're going through. You also want to get to the people who are out in the front lines who are putting themselves at risk. You also want to make sure that the healthcare providers realize how much we appreciate them and the risk that they're taking. But you also have to get to another group that I think is a bit more problematic, the people who, for one reason or other, are getting the misinterpretation that public health measures are in conflict with a healthy society in the sense of economically. It's kind of pitting the economic interest against the health interest. And I try and get the point across as often as I possibly can that we shouldn't look as public health measures as something that's an obstacle to the economy. It's a safe and prudent way to get the economy open again. We're not talking about shutting anything down. Because often when people hear you want to implement things like universal wearing of masks, physical distance, avoiding crowds, that we're talking about the extreme of shutting society down. We absolutely are not talking about that. We want public health measures to be the gateway or the roadway to safely and prudently opening up the economy again. So you could have both. You could have good public health measures and you could still leave the economy open. But when you do extremes, when you say either shut down or do anything you want to do, it doesn't work that way. There's got to be a mean in the middle there where you can do both.
And that's a message that you've definitely been driving in. And unfortunately, against your best efforts, you've also met with some pushback, either from the public or even from the president. And so I wonder, as you continue to tirelessly send out these messages, you're also met with having lived through, unfortunately, a very public experience of what many of us fear, which is the toxic work environment. And you've said you've stuck strictly to business on this front, but I wonder, does it undermine your message to have the president constantly say things that are the exact opposite of what you're saying?
Well, I would say it's certainly not helpful, but that's something that I really don't think I should be, wringing my hands about what I do, since there's a limited amount of time in the day, and to just get your energy focused, as I say, like a laser on what the proper and appropriate public health measure is, and hope that people hear you and understand that adhering to public health measures now is going to make it easier and more quickly getting to where we want to go, is to approaching some form of normality. Luckily, despite the fact that we're dealing with a very, very challenging period right now, even more so as we enter the cooler months of the fall and the colder months of the winter, that vaccines are proceeding at a very good pace, and we should be on time to get an answer. And I think it'll be a positive answer by the end of this year, the end of November, the beginning of December, so that we can start distributing vaccine to those who are most in need, particularly healthcare workers and the vulnerable among us in the population. So that will help a lot, but it's not going to be solving the problem by itself. We will not be able to abandon prudent public health measures for quite some time right now. We've got to make sure that's going to be part of what we do without closing the country, without closing the economy. We can do this. I'm absolutely convinced if, as a nation, we pull together and do some fundamental common denominator public health measures, that we can get through this with a lot of help in the future from vaccines and adequate therapies.
I'm glad you brought up the vaccines, because that's definitely something, everyone is focused on, especially as we know the deadline is coming to get some of those interim results and first looks at the data. I wonder about the effectiveness. That's something that has been a topic of conversation, and I've heard a broad range of commentary from, it will block the virus entirely to it will simply diminish, the most severe cases. And if anyone experiences the virus, it will actually just be a sort of a milder version. So based on what you know right now and what you're seeing, do you anticipate that the first sets of vaccines out the door will be more of a less effective blocker of the virus?
Well, that's a great question, and that's the primary endpoint of most of the virus, is to prevent clinical disease, to prevent symptomatic disease, not necessarily to prevent infection. That's a secondary endpoint. But the primary thing you want to do is that if people get infected, prevent them from getting sick. And if you prevent them from getting sick, you will ultimately prevent them from getting seriously ill. So that's what we want to do. The first point, which we call a primary endpoint, is that if the vaccine also allows you to prevent initial infection, that would be great. But what I would settle for, and all of my colleagues would settle for, is the primary endpoint, to prevent clinically recognizable disease. And that's what we hope happens. And if we do, that will go a long way to diffusing this very difficult crisis that we're in.
Of course, and going to the point that you've made that the vaccine won't be the end of the story, definitely mitigation tactics will remain in place for some time. Going on to the trials themselves, it seems like the UK is setting up to do a challenge trial. And while we already have some vaccines in late-stage trials here, it does seem that with the number of candidates out there, there's some room for using this strategy. Is the US setting up to do a challenge trial as well?
You know, we really don't think that that's necessary. When you have so many infections, I mean, we're having in this country, as we started the discussion off, with over 80,000 infections per day. Fundamentally, when you do challenge studies, there are a number of reasons, one of the most important of which is that there's not enough disease activity out there for your vaccine trial to give you a definitive answer. And even though challenge studies may have a place under certain circumstances, it's not the same as the actual circumstances with which a person gets naturally infected. So although you can get some good information from a challenge trial, the real world information that you want is out in the field when someone is actually being exposed to natural infection and to determine if the vaccine prevents against that. So right now, we're not planning any challenge studies because we have so much infection going on. We have 5 or 6 vaccines that will be in trial in the midst of these 80,000 per day infection. I think we're going to get enough information that we need to make a decision as to the safety and the efficacy of a vaccine without resorting to a challenge trial.
Okay, and speaking of that an unfortunate number of cases in this country, we know that with the cases rising, being in contact with people is getting more dangerous. When we look at sort of the political climate we're in, having to deal with the campaigning, we still see rallies happening. And I just wonder, with the recent reports of aides to Vice President Mike Pence being positive, should these rallies be canceled at this point, this close to the election day?
Well, I'm not going to comment on whether this or that rally should be canceled, except to repeat what I've said many, many times, and I'll repeat it here, that we should avoid as best as possible congregate settings where you have people who are crowded together. If that happens, it should be outdoors, and if that happens, it should be with virtually everybody wearing a mask. So, there are 5 things that I talk about all the time: universal wearing of masks, keeping distance, avoiding congregate settings, avoiding as best as possible indoor things where there are crowded people indoors, and wash your hands as often as possible. That goes for any circumstance, no matter where it is and who's doing it.
Speaking of the campaigns, we know that Election Day is near, and there is either going to be a continuation of this administration or a change. I just wonder what that means for you and your work, what a continuation of the Trump administration means versus what expectations you have of a Biden administration when it comes to dealing with the coronavirus.
Well, from my standpoint, I'm going to be continuing to do exactly the same things that I'm doing right now, putting a lot of effort into getting safe and effective vaccines, as well as better treatments. We have some good treatments. We can do better. We have a number of clinical trials that are going on for early infection to prevent the need for hospitalization. That's not going to change no matter what administration is in. And my message, which is a consistent message, will not change because it really transcends whatever administration. The message is the same, the kind of prudent and careful public health measures that I believe will be able to contain the surges that we're seeing right now. None of that's going to change.
It seems like whatever you do does have some level of insulation from some outside forces. We've unfortunately not seen that with the FDA and CDC. And going global, we've also seen the U.S. sort of miss out on participation with some of these vaccine efforts and other responses. I just wonder, we heard Bill Gates earlier talking about how China is not, in fact, in the driver's seat when it comes to the vaccine. But when it comes to the work that your agency can do, if a country like China does in fact get more attention, does that sway the ability of the U.S. and your agency specifically to do research going forward, to have a commanding voice on the response to the virus?
Not at all. I mean, the NIH and our biomedical research community has always been, is now, and I hope will always be, the dominating biomedical research force in the world. And just about everybody admits that. That's not changed. Whether China does what China wants to do or Russia does what Russia wants to do, what we do with regard to science, the development of therapeutics, the development of vaccines, is something that the world has always looked upon us for leadership, and it continues to this day.
When you talk to some of your foreign peers, I'm sure you're in constant contact. Is there anything that we could be doing better and should be implementing, or other strategies that we haven't tried yet?
Well, I mean, you're absolutely correct. I am in close contact with my scientific colleagues and my public health colleagues, which long antedated COVID-19. So those relationships stay the same. The part of your question, when you look at what we've done, could we've done anything different? It really depends on what you mean. From a scientific standpoint, I think what is going to turn out, and I hope so, I don't want to get overconfident in it, but I think one of the real successes that we're going to see over the next couple of months is what's happened in the arena of vaccines, as well as, in some extent, newer and better therapeutics. So I think we can look forward to something positive there. Could we have done things better from a public health standpoint? Of course. Whenever you're dealing with a very difficult situation like that, you can always look back and say there were things that we could have done better and that we should have done better. But that's just the nature of the situation we're in. I think anyone who says, no, we've done everything perfectly is really not looking at the reality of the fact that when you have such challenges like that, whether you're in Europe or in Asia or in the United States, we could always look back and say we could have done a better job.
Certainly, and with the changing information, I've said often we are watching the scientific process, under a very public light in a way we never have before, and I think everyone's privy to that now. Looking at some of the things we've learned, I think this is something that still weighs on some people's minds. Or what exactly should we be doing? So, for example, bringing your groceries in, is that something that you should still be wiping down your mail? What do you do, Dr. Fauci?
I get asked that question all the time. Well, we know that this virus overwhelmingly, predominantly is transmitted by the respiratory route, by either droplets that are large enough essentially to travel to get to someone's nose, eyes, mouth, or aerosol a little bit. We don't know exactly what the extent of the aerosol is. We know it does play a role. Exactly how much is still being worked out. We also know that the virus can live on inanimate objects. But if you look at the transmissibility, the epidemiology that we have a lot of experience now, that is very likely a very, very minor aspect of transmissibility. We can't say it's zero. It certainly is real and is finite, but it's minor. So I think we should spend less time worrying about wiping down a grocery bag than we should about just washing our hands frequently. So you ask me what I do when I come from the grocery store, or when someone gives me a takeout bag, which I do a lot now because I don't go into restaurants and sit down. I want to keep them going financially, so I do a lot of takeout. So I do have a bag that I bring into my house. Instead of worrying about the bag, I'll open the bag and then I'll just wash my hands thoroughly, which is what you should do. I think doing that natural public health measure and not worrying about touching things, things that might or might not have anything to do with transmissibility, just focus on washing your hands.
Well, thank you for answering that one. That was a personal one for me. Dr. Anthony Fauci, thank you again for your time. Director of the National Institute of Allergy and Infectious Diseases and the U.S.'s top epidemiologist. Thank you again.
Good to be with you. Thank you for having me.
It is, of course, Thanksgiving Eve here in the United States. This as the spread of coronavirus continues across the country. COVID-related hospitalizations currently at a record high. And we have seen guidance from the CDC and others on how Americans should be thinking about staying safe this holiday season. Joining us now to discuss is Dr. Robert Redfield. He is the director of the Centers for Disease Control and Prevention. We're also joined by Yahoo Finance's Anjali Kemlani. Dr. Redfield, thanks so much for joining the program today. I'd love to begin by talking about the holiday, the guidance that the CDC has put out, and what you are hoping Americans will do over the coming days to help as best we can stop the spread of COVID right now.
Yeah, Miles, it's really important because, as you know, we're in a significant surge right now across the country. And it is just so important that the American public redouble their efforts to be vigilant on the key mitigation steps that we do know work. For example, masks. We know they work not only to protect you from infecting others, but also to protect you from getting infected. Hand washing, social distancing, really being smart about crowds, being really select about activities indoor, try to maximize ventilation, do as much as you can outdoor. And this is why we advise the American public, knowing that, this is an important holiday, that we really advise people to reconsider about traveling, reconsider about trying to limit themselves to small gatherings of individuals that actually live in the same home. Because right now, the major way this virus is transmitting around our nation is no longer the public square. It really is these household gatherings. And we have many, 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 many counties now, even in rural areas, that are in what we call the red zone. So we're trying to really escalate our message for individuals to realize we can make a difference. Kansas recently did a study where there was a mask mandate, and some counties opted out of it. Some counties opted in. The counties that opted in had about a 6% decrease in cases per 100,000 in the observation period over approximately 6 weeks. The counties that decided to opt out of that mitigation step had over 100% increase in the cases. So each of these mitigation steps that we've recommended really do work. I know it's difficult. I have a large family, but I think this is a Thanksgiving, and this is a religious holiday season that we're going to have in December, where I think it's much more prudent to be circumspect about travel, about gathering with individuals for meals that aren't part of your own household, being vigilant about wearing masks, hand washing, and being vigilant about being smart about how you put yourself at risk in crowds.
Dr. Redfield, Anjali here, good to talk to you again. I know that you've addressed this already in terms of small gatherings, and there have been some reports that say that it isn't necessarily so. I wonder if you could explain, are there details involved in your saying that small gatherings do contribute to transmission, such as ventilation or wearing masks even when multiple people are indoors? Are there steps that can be taken if someone wants to gather?
Yeah, I think you raised some important points. Clearly, wearing masks is important from everyone in the gathering. Clearly, maximizing ventilation is important. Clearly, maximizing social distancing is important. A number of people who are having these gatherings are opting to have them outside rather than inside. Even though it's cold with heaters. My wife and I celebrated her birthday last night in a small outside table where there was really only one other couple in the outside area, probably separated by 20 feet. And yeah, we kept our coats on, and yeah, it was cold. But these are the type of things we're really asking people to do. Don't let down your guard. And many people do when they're among family members and you're having a celebration meal together. You're taking off your mask. You're socializing in a close space. This is what we're asking people. If they do these gatherings, please wear your mask. Please social distance. Please try to maximize ventilation. Consider doing it outside if it's at all possible. If not, open the windows and doors to maximize ventilation. because the reality is when you look at this surge we're having across the country, you know, it's not like the spring when the surge was in major cities, New York, Detroit, New Orleans, Los Angeles. This surge is really throughout the counties. We have thousands and thousands of counties now, even in rural states like North Dakota, Wyoming, Montana, Idaho, where they have very low population densities, but they're having very high infection rates. And again, it is because this virus is moving silently. It's a silent epidemic. Largely individuals 15 to say 35, asymptomatic, are transmitting this virus. So I know there are some individuals that try to suggest that maybe small gatherings and household gatherings aren't driving this. I think we're confident that this is where the pandemic is centered now. There's been much more, I think, effective attention to the public square, where people are being much more careful. I do think people have a tendency to be less careful when they're in these small household gatherings in their own home. So we've really made it clear when we're talking about having a household gathering, we're really trying to tell you to limit it to the people that actually live in that household, sleep in that household. And when you're bringing other individuals in, then you really need to be vigilant with, like what you said, with the mass social distancing, increased ventilation, and trying to be smart about the interactions that you do have.
Absolutely. Moving on to, we've seen, you know, a lot of travel as well. And I know that the CDC or individuals from the CDC conducted a study about travel-related spread. And it seems like the results of that have led to consideration of a change for the quarantine period down to 7 or 10 days. I wonder if you could elaborate on that and sort of what the thought process behind this change is.
Well, I can tell you we've always tried to use, as you know, CDC is not an opinion organization. We're a science-based data organization. And the data that we do have then defines our recommendations. And as you know, the best data that we had was that individuals, we would isolate or quarantine for 14 days because people that have been exposed could actually become positive for virus somewhere between that. Even if you cut it originally at 10 days, you may miss some individuals. We've continued to study this aggressively in a variety of different settings. And that data is now being critically reviewed and put together. And based on that data, I anticipate we're going to revise our recommendations. So it's we're constantly doing more and more research to try to validate our recommendations and see if they can be improved. And I do anticipate that we will come out with new recommendations that look at a shorter period of quarantine and even a shorter period of quarantine where you would test out of quarantine. I don't want to get ahead of the recommendations. I know there's been some talk in the press about it, but I do expect that in the next week or so, that data will be completely analyzed and then the recommendations will be made based on that data.
Doctor, in terms of a vaccine, how severe do you think the side effects will be to a COVID-19 vaccine, and what should the American public expect when they do take this vaccine?
Yeah, I think it's important. I've seen there's a lot of reporting on this recently. Obviously, as the FDA finishes their formal review and issues the EUA, there'll be comprehensive data there related to safety, adverse reactions, and side effects. And that information obviously will be transparently presented to the American public. Our advisory committee on immunization practices will put that together along with the recommendations that come from the FDA. I anticipate so far that this is a relatively safe vaccine. We haven't seen many serious adverse events, as you know. Obviously, there are reactions that we see with many vaccines between injection site soreness and sometimes some systemic symptoms of feeling like you have a flu-like illness. But I think let's wait till the analysis is complete and those data will be presented in a transparent way to the American people. I will say that for those people that are at risk for a serious outcome, or those people that are at risk for being infected and being a silent spreader to somebody else. I think this vaccine is really going to be a game changer for us in this pandemic. We're hopeful that the American public will embrace it. Obviously, we're going to present the information as clearly and transparently to the American public as we can.
Dr. Redfield, finally, if I may, sir, you sound a little weary, and I think we're all a little weary, but you especially, I mean, this advice that the CDC and other health professionals have been giving for so many months now about wearing masks and social distancing is not being taken to heart by all Americans, or else we still wouldn't be seeing this spread. As we look ahead to future pandemics and to whomever your successor at the CDC might be, what advice would you give them? What is sort of the central lesson we have perhaps learned throughout the course of this pandemic that we can pass on and apply in the next situation?
Well, it's an important question. I know when I finish my tour of duty, reflecting on it substantially, because I think that's really the key. What lessons were learned so that you can kind of articulate and share that. I think for me, if there's any disappointment, is that we didn't come together, I think, effectively as a nation and really hone in and reinforce a central message. Masks work. There's no question about it. The science is clear. And yet, I'm sure you can have 10 people get on your show and tell you that masks don't work. And this is difficult, when the American public is trying to understand, what message do I accept? I'm trying to, we have tons of evidence. Some of it is, when you're getting a new pathogen, as we did. I mean, when it first came, we were looking at this like flu. And so people were assuming that the real target that we had to focus on was symptomatic illness. And then once we had symptomatic illness, symptomatically ill patients should then wear masks. And then all of a sudden we learn, wait a minute, this virus isn't like flu. It's not like SARS. This virus actually transmits really well asymptomatically. And then that's what led us to understand that we needed to get source control. And so we needed everyone to wear a mask because we didn't know who was infected and who wasn't. And I think that transition of message from January and February to April 3rd, when we issued our mask guidance, a lot of people exploited that and basically put doubt in whether masks work or don't mask. Sadly, that issue became politicized. So what I would say is the biggest lesson that I've learned, it's how critical it is to have unity in message, unity in message, unity in message. And you're right, we keep repeating the same message, but I'm hopeful, particularly now as people see what's happening, the spike in cases. We had over 1 million cases in a week, last week. Now getting back up to 1,500, 1,700, 1,900 deaths a day. My hope is that people will take that message again and realize now, particularly because we have a vaccine that is going to be available starting in a couple of weeks, and then over the next months ahead, between now and probably the end of the second quarter, beginning of the third quarter of 2021, the American public is going to have the benefit of being vaccinated, and we're going to be able to put this pandemic behind us. So it's so important now not to be in the last group that ends up with a serious fatal outcome, because, my 8-year-old child who works in a hospital comes home and inadvertently infects me and my wife. I think we have to be vigilant now, not give up on it. But to me, that's the biggest lesson is if we had unity as a nation of message, using the tools that we have, hopefully we can still get there for December and January and February and sort of rally around the reality that the vaccines are here. There's a light at the end of the tunnel. The cavalry's coming. We're going to get the vulnerable vaccinated. We're going to make sure we start to confront this pandemic and really put it behind us. And then we can turn our attention to helping the rest of the world, particularly resource-limited areas, begin to get this pandemic under control for them also.
Dr. Argerfield, a final question on that vaccine distribution. I know that the advisory committee did recommend that essential workers get vaccinated before the elderly, and it seemed to make a lot of health equity advocates very happy. But then we heard Secretary Azar yesterday say that it was really up to the states. Where do you stand on this, and what can we expect in terms of actual distribution?
Well, we're still in discussions, as you know, to make the final recommendations that we will have from CDC. What has been determined, as you know, and as Secretary Azar and Operation Warp Speed have probably articulated the other day, is there is a distribution to each of the 64 jurisdictions that is going to be done based on the amount of vaccine we have, based on population size. But the micro distribution, once that vaccine is within those states, clearly CDC is going to give clear guidance. And as you mentioned, whether it's healthcare workers, first responders, whether it's the most vulnerable, whether it's strategic in trying to maintain healthcare resilience, obviously individuals in nursing homes, those final recommendations will be forthcoming shortly. But at the end of the day, the vaccine is going to be delivered to these jurisdictions, and what I call the micro distribution plan will be executed by the individual states based on how they finally decide to do it. CDC sent out a playbook back in July to have each jurisdiction, 64 jurisdictions, start to figure out how would they distribute this vaccine to their population. They worked on them. They completed them by late September, early October. We went back and forth to make sure there weren't any gaps. And so each of these jurisdictions do have a plan. That plan may be modified based on the final recommendations from CDC, but ultimately the decision on exactly how to distribute this vaccine will ultimately be made by the individual states, as Secretary Azar said the other day. But we will be giving our recommendations, how we believe this vaccine should be distributed at this moment, and I expect those to be forthcoming shortly.
All right, Dr. Robert Redfield, the director of the CDC. Sir, you've been very generous with your time this morning. We really appreciate you joining the program. Have a great Thanksgiving.
Yeah, God bless you all. Be safe. Thank you.
On the coronavirus front, we have more than 14.9 million cases of coronavirus in the United States right now, and the death count has risen to nearly 285,000 deaths. But I want to start today's show on this important moment that we're seeing in this fight against coronavirus as the first people are starting to get vaccinated against COVID-19. Today, the FDA said Pfizer has, quote, provided adequate information to ensure the vaccine's quality and consistency for authorization of the product under an EUA, that is the emergency use authorization. They are due to authorize the vaccine in just a few days. But I want to dive into this more now with Kathleen Sebelius, the former Secretary of Health and Human Services under President Obama. We also have Yahoo Finance's Anjali Khemlani here for this conversation. So, Secretary Sebelius, I want to start with you. There's been reports that the Trump administration could have purchased more than the agreed upon 100 million doses of vaccine from Pfizer. They had the option as well to purchase 500 million more, but they have not yet seemed to exercise that option, which some folks are saying could place us further back in line. The U.S. government has said that they were being prudent when it comes to this decision. I know that you've had experience with these, large vaccine purchases, these orders and the distributions. I'm wondering from you if this was a good call or if you think that the U.S. government was, as they were saying, being prudent not to purchase 600 million doses of coronavirus vaccine from Pfizer.
Well, it's hard to second guess, and I don't know what the negotiations were. I think hindsight is always better than foresight in these situations. The hope really is, Kristen, we will have multiple vaccine candidates that will be equally effective and be able to target them to the appropriate population. So I'm hopeful that this won't be a decision that will be regretted looking back. the United States, I'm more worried about the United States not participating in any of the global discussions, making sure that vaccine is going to be widely available throughout the world, because in addition to our population, as long as people travel and we get back to travel, as long as folks are not vaccinated everywhere, we are still liable in the United States to have the disease tick up again. So we not only have to look out for our population, and that's about 600 million doses that are going to be needed to vaccinate our entire population, but also be a leader in getting this vaccine quickly to developing countries so that travel and business can resume on an adequate fashion as quickly as possible.
So speaking about that vaccine distribution, as you mentioned, some 600 million doses that are going to be needed here in the United States, since it is, just as a reminder for everyone at home, a two-part vaccination process. 2 shots are going to be required. Now, you oversaw the vaccine purchase and the distribution of the H1N1 vaccine back in 2009. Which had a slow start back then. And I was reading at the time that you were blaming production problems, and there wasn't this same hurdle that we have now with this ultra cold refrigeration that's going to be necessary as a part of this process. Given your experience, I'm wondering what your biggest concerns are that you have looking forward at the vaccine distribution here in the United States, which could start as soon as next week.
Well, my biggest concern is that there's not a clear plan right now with this administration. They push the decision-making in way too many areas to governors, and governors are really left on their own. So now the CDC has prioritized populations to at least receive the first very important doses. Pfizer has already backed off what they thought they could deliver by the end of the year. They now have lowered that number. That's exactly what we experienced in H1N1, that the numbers out of the vaccine makers were not intentionally devious, but they were wrong. There will be things that happen with batches. There will be things that happen along the way. What I understand is that governors are now trying to figure out how to get vaccine that may be delivered to their states into these various populations. That's all being left to individual governors to figure out cold storage pathways, to figure out how to get things to the right places. In a small rural state like Kansas, there are some pretty isolated hospitals, healthcare workers, nursing homes. It isn't an easy distribution operation. I think the Biden team has a much clearer plan being developed right now. We had a big problem with getting the vaccine, which we had plenty of, into syringes. It turns out that our bottleneck was really in the fill and finish portion of the vaccination. To get it to the arms of folks, you got to get it out of bigger containers into syringes, get those syringes to the right places, get them distributed. And as you say, this logistical nightmare is made more difficult by the cold storage required by particularly Pfizer. Moderna doesn't have that same level of cold storage, and other vaccines may not. But for the Pfizer vaccine, this is super cold temperatures. It needs to be kept there for the time period or packed on dry ice. But as you look at where people are and where they're living and how to get it there, this is a huge challenge. And right now, it's being left on a state-by-state basis to figure it out. So think M95 masks, where there was bidding against one another and attempts to get all the same equipment. People are now ferociously going after cold storage containers, trucks, to try and figure out how to get it from place to place. And it would be so much better, and will be better, I think, once we get a national strategy and have the federal government commit to making it as easy as possible to get this vaccine to the people as quickly as they need it.
Secretary, it's Anjali here. I know that, Operation Warp Speed attempted to address one of those problems, right? The fill and finish part with the various contracts with the syringe and glass vial companies. But looking forward, we know that the meeting on Thursday with the FDA's Vaccine Advisory Committee is really set to go rather quickly. It seems that some institutions are readying their troops for December 15th rollout of the vaccine in-house in some health facilities. accountability. So what should we listen for? What do you expect out of that meeting this week?
Well, I think that, first of all, I will acknowledge that what we are seeing right now is a remarkable step forward, that there is light at the end of this tunnel, that there is a horizon where we can see effective vaccine reaching vulnerable people and stopping this horrific death toll and the economic fallout that comes from the virus. So that's all very good news. The next steps are a logistical nightmare, frankly, because it is a complicated process to get one dose throughout the country. We have complications on top of that. And I would say at every point along the way, however many people there are in a category, there won't be enough vaccine. So we're going to see a situation where governors are going to have to make very tough choices. Healthcare providers are going to make very tough choices. They will not have 100% of the vaccine needed to get all the healthcare workers. So who gets at the front of that line? How is that prioritized? There won't be enough vaccine in the next dose for all the nursing home residents and staff. And I think we need to urge people to be a bit patient, as difficult as it may be. Follow the social guidelines as much as possible. Social distancing and mask wearing could not be more important than right now, because we have months to go before we have an effective vaccine reaching a population sufficient enough to have herd immunity. And ironically, that is what herd immunity is about. It's how many people do you have to vaccinate in order to protect others. And the estimates of the public health experts are in the 65 to 70% range, should give us some level of herd immunity in the United States. And that's going to take a while to get to.
Absolutely. I want to pivot just for a quick second to the new HHS secretary pick for the Joe Biden administration. Having been in the position, I know that there have been some comments about the lack of healthcare experience. I wonder, from your perspective, is that really relevant? Should that be something that people worry about?
Absolutely not. I think that, first of all, I would put Javier Becerra's healthcare experience up against lots of us who have served as secretaries. He was a key lieutenant in passing the Affordable Care Act. He's been in the courts defending the Affordable Care Act, so he knows intimately the most important piece of health legislation in the last 50 years. He also has worked in Congress on everything from issues involving immigrant children and families to disparities on health care. If you think about what COVID-19 has peeled back about health disparities and shined a bright light on, he is ideally suited to be the secretary in this day and age. He's worked on the opioid epidemic. He has a track record on healthcare mergers, which are seen too often as rising prices and not providing additional access to consumers. So I think he's run a big organization. I mean, the Justice Department in the state of California is bigger than many states, and governors are often tapped for HHS. But I would say that he comes with management experience, with congressional experience, and with the kind of leadership on key health issues that are so important to people across this country. I think he's a terrific pick for secretary.
Secretary, I want to circle back to something that you were saying just a moment ago. When it comes to the Trump administration and the leadership, or some of the criticisms that you're levying about the leadership, lack thereof, when it comes to their strategy in fighting the pandemic, I know that you've praised Operation Warp Speed, but we've talked to a former CDC officer, Dr. Rishi Desai, and he said flat out that he believes the Trump administration is going to bungle the vaccine distribution. I'm quoting him here, because of their inability to get PPE out to all frontline and healthcare workers. And this is a criticism that you've also levied against the administration. Given all of the hurdles, some of the concerns that you were highlighting just a moment ago, and even some of the criticisms that you were mentioning just a moment ago, I want to put that question to you. Do you think that the Trump administration is going to be able to handle this vaccine distribution, which could be as early as next week? Or do you think that we are going to see a lot of failures in this vaccine distribution? Will the administration be bungling this distribution?
Well, I'm very concerned about what seems to be the lack of a coherent plan. Other than Operation Warp Speed, where the Trump administration put all the muscle of the federal government combined with the innovation and expertise of the scientific community and money behind it and said, go as fast as you can. Let's get rid of the bureaucratic hurdles. Let's move. That has been a terrific success. They have refused to use the muscle, the logistical strength, the financial leverage of the federal government for any other part of this pandemic response. And that's a huge problem. They do not have a plan right now to use the federal muscle, the federal logistics, the federal government beyond getting the vaccine into states. And then it's up to governors. We've seen that playbook. It is a failure. When the federal government doesn't mobilize PPE and distribute it in a fair and equitable and transparent manner, when the federal government doesn't put in place the right kind of test and the testing protocol and ramp up those tests and distribute them fairly and equitably, I think we may see a repeat of that with the vaccine. Real mishmash of efforts. States are left on their own. Some have resources, some lack the resources. All state governments are struggling right now because of the failure of Congress to push through another relief package. And, you know, the federal government will stand on the sidelines saying, basically, we did our job, our hands are clean, and we got vaccine to the states. Well, that doesn't get it into the arms of the population who needs it. And without that help and support that we cannot count on until the Biden team gets in place on the 20th of January, we may see a lot of missteps along the way.
All right, Kathleen Sebelius, former Secretary of Health and Human Services, as well as Yahoo Finance's Anjali Khemlani. Thank you both for participating in today's conversation. The president of the International Federation of the Red Cross has labeled misinformation as another pandemic, one that could slow down the fight against coronavirus. Here to talk this and more, we're joined now by Dr. Emanuele Capobianco, Director of Health and Care for the International Federation of the Red Cross. Doctor, so the president of the Red Cross said misinformation needed to be combated. I'm wondering from you, how difficult do you think fake news, as we like to call it here in the U.S., is going to be making vaccine distribution?
Well, fake news have been problematic from the beginning of this pandemic, and now are becoming even more difficult when new vaccines are planned to get into many countries in the next weeks or months. And I think on one hand, we need to combat fake news by bringing forward the positive news, the right information, to keep people really on top of what is happening in a fairly rapidly evolving scene. And the other one is trying to also understand what is driving the fake news and try to listen to the concerns that are being raised and respond to those concerns so that we can hopefully address many of them and bring those people that are on the other side of the fence on what is probably the right side of the fence.
So, Doctor, speaking about some of those concerns, the UK has already approved a vaccine from Pfizer, which has been met with, some criticism and pushback, at least here in the United States, from Dr. Fauci. Let's take a listen to what he had to say.
If you go quickly and you do it superficially, people are not going to want to get vaccinated. We have the gold standard of a regulatory approach with the FDA. The UK did not do it as carefully. They got a couple of days ahead. I don't think that makes much difference. We'll be there. We'll be there very soon.
So some pointed words there from Dr. Fauci that the UK went a little bit too fast when it came to approving this vaccine. I'm wondering if you think that the United Kingdom went a little bit too fast, and if you have any concerns about this vaccine and about rolling it out to hundreds of millions of people.
So let me just start by saying that having a vaccines potentially available within a year from the discovery of a new virus is something extraordinary. Having a vaccine that potentially has an efficacy, as has been reported, above 90% or 95% is another very good thing. Now, what we need at this moment is to have regulatory authorities all around the world certifying these vaccines independently in terms of safety and efficacy. And that is what is happening in the United States with the Food and Drug Administration process, what is happening all around Europe through the European Medical Agency, that it will be reviewing extremely carefully these files, and only after careful review, the vaccines will be allowed to go out and be provided to people that need it. And so we need to trust these independent systems that have been there, established, and have been reviewing plenty of drugs and vaccines that have come to us. And once we have that clarity, then we'll have to confront the new challenge of bringing the vaccines to the people who need them. And that is going to be quite a massive feat that will take a lot of efforts throughout 2021 and possibly beyond that.
I'm really glad that you mentioned those challenges, because the Red Cross, by its nature of responding to international crises rapidly, deals with huge logistical challenges all the time. I'm wondering what you see it is needed for a country like the United States to roll out a vaccine to hundreds of millions of people. And I'm wondering if the Red Cross is going to be involved in the distribution of vaccines, either here in the United States or in other countries around the world.
Well, thank you for the question. First, the first obstacle is ensuring that we have enough doses for the people who need them. And, you know, for some countries that have been procured in advance, the vaccines, doses will be coming in the next few months. There are a lot of countries, particularly poor ones where the Red Cross operates, that have not been so lucky and that really risk to remain behind. And we are very concerned about that. There are some international mechanism like the COVAX facility that can actually support the procurement and distribution of vaccines in poor countries, and we hope to have that more financed in the next few months. Now, the second problem is then once you have the vaccines to really distribute them through the population, that's going to be a massive logistical effort, particularly for vaccines that require cold chain facilities that can preserve the vaccines at minus 80 degrees. It has been done. We have done it in Congo with Ebola, but it is a difficult task, particularly because we are not talking about a few hundreds, thousands of people to be vaccinated. We are talking about millions, billions of people to be vaccinated. And the Red Cross will be there providing support in many countries. We are doing a lot of advocacy. We're going to do a lot of social mobilization of people in countries to fight exactly that vaccine hesitancy that we talked about later, and then we will be there to support the vaccination efforts. And right now, our national societies in 192 countries are actually, in talks with authority to see how our 40 million volunteers can help in the best possible way the national efforts that will be run and led by governments in the different countries.
So looking here at the United States, Doctor, obviously we have a federal government, but we also have states and local governments. This provides its own challenges, right? When it comes to an effort as large as vaccinating hundreds of millions of people, 330 million people here in the United States. Just based on your expertise of, rolling out, vaccines across a country, do you think that an effort like this really needs to be something that is handled on a national level instead of, handed out to states to tackle on their own?
It's difficult for me to respond to a question specific to the United States, but I would say that in general, what you want is national plans that then are adapted to the regional or provincial levels in order to get all the steps lined up and prepared very carefully. What is needed at this moment is preparedness plans that are actually written and developed at all levels so that when the vaccines come, things can proceed smoothly. And we know that all vaccine will not be coming at the same time, so there will be a progressive increase that will hopefully give us time to get ready in the US as in other countries. So we're not going to have 280 million vaccines tomorrow, unfortunately. They will be coming slowly, and that's why the authorities are now prioritizing who should get them first, starting with the healthcare workers, frontline workers, and then the people, the oldest people in home cares.
Right. Well, some good logistical insight there. Dr. Emanuele Capobianco, Director of Health and Care for the International Federation of the Red Cross. Thanks for joining us today.
Thank you very much.
Joining me now is Melinda Gates, co-chair of the Gates Foundation. Melinda, good to see you again. Thank you for taking the time today.
Thanks for having me, Brian.
So the foundation is pledging $250 million in the fight against COVID-19. That is the largest single contribution to the response to date. How will the money be allocated?
We're looking at making sure, our whole goal is to make sure that these vaccines get out to low and middle income countries. So part of this money is going to be used on procuring 200 million doses of vaccine for low and middle income countries and procuring 120 million rapid diagnostic tests for low and middle income countries.
How concerned are you about vaccine nationalism? Because when I see a pledge like this, really it's forward thinking, it's needed, but you hear so much talk that the vaccines will be concentrated in the U.S., the U.K., Europe will get their fair share. But to your point, really it's those small countries that will be hurt.
I'm deeply concerned whenever I hear about vaccine nationalism. I think we have a moral responsibility to make sure everybody gets vaccine. If there's an estimate that says that if only high-income countries get vaccine first, we're going to see twice as much death around the world, and we're going to have a much, much slower recovery of all of our economies, not just the middle and low income, but even the high-income countries.
What are some of the barriers to getting the vaccine into the arms of folks in those lower income countries? It's not necessarily just getting the vaccine to the country. How do you get it into the arm? I mean, we don't even know. We have logistical challenges here in the U.S. with cold chain storage. How could it be done successfully?
Well, you have to do a lot of good planning up front, and that needs to be happening now. But it is possible. We have a global mechanism that was set up about 20 years ago. We are part of this. We're part of setting it up. It's called the Alliance for Vaccines and Immunization. What we can do is procure vaccines, and through Gavi, there is a whole distribution system that exists out in low-income countries that it comes to the hub, let's say in Kenya, in Nairobi, and then goes out to all of the country. It's totally possible. You just have to do the planning now.
Mm-hmm. How difficult will it be to get the vaccine distributed successfully, even here in the U.S.? There is a lot of optimism, and it's good to hear. We need this vaccine. We need it out. But this thought that you could just have the military distribute a vaccine and states will do their thing, there just doesn't seem to be any coordination.
Well, if you empower the CDC in the right way, the CDC is completely set up to help make sure that the right things are done in state after state and local region after local region. So again, it just takes very good planning to figure out which states get it, and then up for states to decide, okay, what part of our healthcare workforce gets it at the same time as the elderly, and then who gets it after that. But it's completely doable in a country like the United States. I'm not saying it's easy, but it's absolutely doable.
Based on your conversations with leaders across the world, is it too optimistic to expect half of the U.S. population to be vaccinated for COVID by the middle of next year?
I think by middle of next year, you could see half the U.S. vaccinated, because we have these two first mRNA vaccines coming, but then there are 3 more that are going to come very quickly behind that. Those are even easier to manufacture, and so I think you'll start to see lots and lots of doses available.
Your husband, Bill Gates, mentioned in a recent interview that things will be back to normal, or start to get back to normal, by the middle of next year as the population gets vaccinated. What do you think normal looks like? What is the new normal for corporations, or more broadly, just for humans?
I don't think we know what the new normal looks like. I think it's going to be different than the old normal, but how we do this, if you're lucky enough to have a job that you can do by screen and do from a different office or from home, I think we're going to go to hybrid models of that compared to what we've had in the past. I think education and schooling, I think we're going to put lots of kids are going to return to school, which would be fantastic. That's much needed. But I also think hopefully we'll start to learn some things from the digital models that were used by middle and high income kids of how to do some hybrid learning to help catch up kids who didn't have access to the digital tools. So I think there's going to be a lot of things that shift, and I think it's going to be a little bit hard to predict right now.
How do you expect to allocate more funds moving forward as the vaccine rolls out? What's some of your thinking on how the foundation could help?
Well, the foundation, with this new announcement that we've made today, is now we've committed over $1.75 billion to COVID tools. And that is to really make sure that we've done this incredibly difficult work as a scientific community. It's unbelievable. I mean, if you think about sitting here last March 30th, we would not have all thought we'd have vaccine here in December being given out, so approved and then started to roll out. So that initial piece of hard work is done. There's still a lot more science to come, but now we're really focused as a foundation on how do you get out to everybody and how do you get it distributed and keep everybody safe with the right tests, contact tracing, mask wearing, and the new vaccine as its tool.
Mm-hmm. Is the FDA still the gold standard? The FDA has come under a lot of fire, but should people still trust that the FDA will approve a vaccine that they can put successfully in their arm and not get sick?
Yes. The FDA is the gold standard in the United States. There are very good people who work on those regulations, and they are not going to let a vaccine come out until they know that it's safe and efficacious, because we rely on that to know that what we're putting in our bodies is safe. And so absolutely. And once they approve a vaccine, as soon as it's my turn to take it, when it comes to my age group and my risk profile, I'm getting it the day I can. But that will be after healthcare workers and the elderly.
There is a problem here too, vaccine misinformation. You can really go down a rabbit hole on social media with some of this information. How do you think that will hurt or hinder the uptake on the vaccination?
Well, we already know there's a tremendous amount of vaccine hesitancy because of the disinformation. And the disinformation is incredibly unfortunate because it actually results in people's deaths. If you don't do the right thing, you get COVID and you could die. So I think, people do go down, as you say, a rabbit hole on some other piece of disinformation. And then unfortunately, social media then serves up more disinformation. But one thing that I do think will happen is as the vaccine rolls out and we see healthcare workers safe, we see teachers returning to school, we see the elderly are safe, I think people start to ask their doctor, is this right for me? And then they'll decide to take it. So I think we will turn the tide on this, but I think it's going to take some time. But I think, you'll start to see the tide turning, I think, by next summer.
Do you think big tech has a role in helping to get rid of this misinformation? Melinda, I don't see them stepping up here, or thus far.
Well, I think you're seeing some of them do the right things to keep disinformation off their platform and to stop it or take it down. But I think absolutely more could be done. I think, social media has risen very, very quickly in society, and even the way it's used is changing. Honestly, it feels like in my teenager day by day and that age cohort. But I think the regulations have not only not kept up, they haven't gotten ahead of it. And I think it's time that they do. We have good regulations for TV broadcasting that were set many, many years ago. We have good regulations in the motion picture industry. It's time to have some good regulation on these social media platforms.
Have you talked to President-elect Biden and his administration yet on how the foundation can be helpful?
Bill and I have spoken with President-elect Biden, and the topics that wouldn't be surprising to you are the pandemic, because that is first and foremost of the things that needs to be done. We've spoken with him also about climate change, because he plans to re-enter the climate change leadership on the global stage, and also about caregiving in this economy, that if we are going to get back to work, we've got to fix the broken caregiving economy for children and for the elderly.
Well, you gave me three things there, so I just wrote that down. I take notes quick in my increasingly older age. What do you think we will see from the Biden administration within those first 100 days as it pertains to the pandemic?
Well, we've already seen him announce an eminently reasonable group of wise people on his COVID task force. And so I think you're going to see him re-enter the global stage. He knows the importance of diplomacy from his many, many, many years as a senator and as a vice president. And I think you'll see him re-enter all kinds of global mechanisms like the World Health Organization, like the Paris Climate Treaty. I think you'll see global leadership from him with many of the other nations that have come together to make sure that COVID tools are accessible by low and middle income countries. He knows that for a robust return and recovery in the United States, you've got to get the rest of the world vaccine as well.
Do you think that we have not had that under the Trump administration? How much do you think that has set us back in this fight? The fact there really has not been any globally coordinated response.
I think we wouldn't have so much death in the United States starting there if we'd had an appropriate response from leadership. And yes, I think the U.S. is missing on a lot of these global stages related to the COVID-19 tools. And that's been unfortunate. It's going to take some time to rebuild that. But believe me, people want the U.S. there. Again, we want to get the global economy up and working. Like the Eurasia Group forecasts that for the United States, we can add $200 billion to our own economy in the next 5 years if we get other countries vaccinated, because then you can get travel fully back up and running. You can get manufacturing and supply chains fully up and running. So it not only makes moral sense, it makes huge economic sense for the United States.
You mentioned caregiving, and this is a topic that I'm sure is near and dear to you. You've written extensively about it. What would you like to see the Biden administration do as it pertains to caregiving?
I would like to see them put in a leader very high up in the administration to coordinate across agencies, because care means caring for the elderly and children. We have 800,000 people on the Medicaid rolls, elders who can't get elder care. So I want them to fix that. I'd like them to put $50 billion into the child care industry that's teetering on the brink right now of failing. And if they do that in long term, put in paid family medical leave, we can get women back to work. I believe we want women to work in this economy. They're 88% of our healthcare workers. They're the vast majority of our teachers, of our frontline workers in grocery stores. But 865,000 women stepped back their careers in September. 1 in 4 saying they're thinking of downshifting. We won't get women working again. We won't get the economy up and running again unless we deal with this child care and elder care.
So it sounds as though, really, this is a major impediment to an economic recovery, right?
Yes, we will have a slower economic recovery if we don't deal with this care crisis we have.
And a caregiving czar, right? Would that be fair to call that?
Yes, definitely. Because that person at a high level can coordinate across the governmental agencies to get done what needs to be done.
And before I let you go, I just have two more for you. So if we were to be sitting here a year from now, where do you think the globe is in the fight against COVID?
I think you'll see a year from now quite a few of the high-income countries returning to whatever the new normal is and starting to make a slow recovery though, but people back out living their lives and in the workforce. But I think it's going to be yet another year beyond that, the end of 2022, that you'll start to see low and middle income countries starting to have full workforce back in production and their economies returning.
You know, your close friend Warren Buffett, the chairman and CEO of Berkshire Hathaway, for decades has warned about pandemics. You know, as you take a step back here and perhaps reflect on where we've been the past year, do you think the government and the globe is in any way prepared for the next pandemic?
No, we have a lot of work to do. There is something called the Center for Epidemic Preparedness that our foundation is part of setting up, but it needs a lot more financing. It needs a lot more structure to think about how do we prepare. And quite frankly, it needs to practice what happens, not if, but when the next infectious disease comes. And if that preparedness is pulled together and coordinated, you are going to have other infectious disease outbreaks, but we'll be able to tamp them down sooner before they travel around the globe.
You know, just based on what we've seen of so far from the pandemic, has that changed how you plan for the future as it pertains to the Gates Foundation?
Well, we haven't done our post-mortem yet, and I don't think we will until we're fully out of this crisis. But, you know, a lot of our work has been set back. You know, for the first time in 30 years, people living on extreme poverty has actually gone up. 37 million more families are in extreme poverty. So we will step back when COVID-19 is over and say to ourselves, okay, where do we need to rebuild, for instance, our parts of our malaria program, or how do we push forward the vaccine work? So we're continuing to do all of that work during COVID-19, but it's all gotten harder. But I don't think we'll reassess our priorities. Our priorities will always be helping people live, no matter where they are, a healthy and productive life.
I said this to you back in April 2019 when we talked last, and I'll say it to you again. I think what you're doing at the foundation is absolutely tremendous. We will leave it there. Melinda Gates, co-chair of the Gates Foundation. Always good to speak with you. Stay safe, and we'll talk to you soon.
The work is not done, but people should be excited. They should be optimistic. In the first surge, it was really about flattening the curve so that we didn't overwhelm our healthcare system. The second curve was about getting through the summer and really trying to save lives. This third surge, we now have a finish line in sight, and it's about running through to the tape. If you're getting to the end of a marathon and you can see the finish line, then it should give you the courage, the strength, the fortitude to keep on going. And I want people to know it's going to be a really hard next 3, 4, 5 weeks, because we've had record cases and those are going to continue to turn into hospitalizations and deaths. But that we have a finish line in sight, and we need to keep washing our hands, wearing masks, watching distances, and particularly during the holiday season, keeping gatherings small and smart, meaning within the people of your household, with the knowledge that once those loved ones can get a vaccine, we can have huge gatherings next year, and you better invite me.
Definitely. And looking at that, we know that, you know, with the timeline, there's still so much more time before the average American gets to have a vaccine. Of course, that's because of the prioritization that the CDC has determined. But looking at it from that perspective, it still leaves a lot of time for people to continue to wonder, to maybe lose interest. So there's a lot of conversation, right, around the anti-vax individuals and messaging, as well as people looking up terms such as Bell's palsy and autism and the side effects of this vaccine. What's your message on that?
Well, my message is that it's okay to have questions. It's not okay. It is absolutely not okay to let misinformation and to let people spreading misinformation rule your life and cause you to make bad choices. You brought up some specific things, and I usually try to avoid lifting up myths, but I do want people to know it has been unequivocally proven that vaccines do not cause autism. When you hear about Bell's palsy, the incidence of Bell's palsy in the vaccinated group in the UK was the same as the incidence in the regular public. So it's not like this vaccine has any indication that it's going to cause any safety problems for anyone except for people who have a history of severe allergic reactions. And that's the case for any vaccine. If you have a severe allergic reaction, talk to your healthcare professional. One thing you can do right now is go to vaccines.gov or cdc.gov and There are frequently asked questions on those sites about all sorts of vaccines. And you can also get your flu shot. Incredibly important right now when you're waiting for the COVID vaccine to get your flu shot this year, because you don't want to be taking up a bed that could be used to keep a COVID patient alive through next year. And that's a great opportunity to ask your provider, your doctor, your nurse, your pharmacist about vaccines and the COVID vaccine.
Absolutely. And talking about getting those shots, we know that companies have frequently been involved in flu vaccinations every year, making sure their employees get it. But with the COVID vaccine, there seems to be controversy over whether or not companies can mandate a vaccine before an employee returns to work. Do you have guidance on that?
Right now, we are not recommending that anyone mandate a vaccine. This vaccine hasn't been fully approved yet. It's been authorized, and that means that scientists, the FDA, and independent scientists feel that the benefit far outweighs the risk. What's interesting is you talked about vaccine confidence. One of the challenges is that vaccines are victims of their own success. Very few of your viewers know anyone who's ever been hospitalized for measles. They probably almost none of your viewers know someone who's been on a ventilator because they had polio and needed to be in what was called an iron lung. And so people don't see the benefits of vaccines. They only hear about the potential downsides. Well, guess what? This COVID vaccine is going to have clear benefits for people. And that's why you're hearing 70, 80% of people are saying they're interested, because they know it can protect them, protect their families, and help us get back to normal as soon as possible. So please, don't let misinformation and people out there spreading it rule your life. Get the facts yourself. And I think when people do, they're going to be just like me. I'm going to get the vaccine as soon as I am able to, as soon as my priority comes up, because I want to be an example for everyone else out there. I've seen the data. I know these vaccines are safe, and I know that they're 95% effective, which means that they can help us get back to normal.
I'm so glad you brought up taking the vaccine yourself. What is the administration looking at, and especially also the incoming administration, if you've had conversations with them about, handing off sort of this tactic and strategy, about how many influencers or celebrities can be brought in to the fold to take the vaccine publicly and enforce that message, just like you and others in the administration are willing to do?
Well, we aren't going to have vaccines for everybody right away. We're going to have enough to vaccinate 20 million people by December, 50 million people by January, and a total of 100 million people by February. So that's about half of the adult population. But that said, we want to immunize for impact right now. And that means older people, people in nursing homes and long-term care facilities. That's why we've emphasized those groups first. And then healthcare workers, because they're most likely to be exposed. Again, immunize for impact. And so the reason why I explain that is because we want to make sure influencers are getting the vaccine publicly so that it encourages other people to do so. But every person who gets the vaccine who's not in a high-risk group is potentially a person who is in a high-risk group who can't get it. So we are thinking very carefully, very intentionally about the risk-benefit ratio of getting certain people vaccinated out of their turn. And that's something that really deeply matters to me, because if I can encourage people to get vaccinated by getting it myself publicly, I absolutely want to do that. But the last thing I want to do is take a vaccine away from a vulnerable older person in a nursing home who would otherwise die if they didn't get it.
One of the things, and of course for you this also holds true, one of the things that's key is also getting the message out to the minority population. In the vaccine kickoff event at GW on Monday,
we must first acknowledge this real history of mistreatment and exploitation of minorities by the medical community and the government. Then we need to explain and demonstrate all that has been done to address these wrongs. So glad you brought that up. And that's why I keep saying it's okay to have questions, because there are some real harms that have been done to people of color in the past in the name of science by the government, by medical officials. The Tuskegee experiment, Henrietta Lacks, who got her cells taken without her permission. And so people rightly have some distrust based on what's happened historically.
And really quickly, you've done all the traveling to different parts of the country. What lesson have you learned about crafting the message correctly to reach the various minorities? What are some golden nuggets of knowledge you could share?
Well, again, you have to validate people's concerns. You have to understand that they have good reasons for distrust. One of my favorite things is that people need to know that you care before they care what you know. And that's why I've been traveling around the country, meeting people face to face to show them that I care. I also want people to know that vaccines have benefits beyond just helping you. They help your community. They help people like my wife who's got cancer and is in treatment right now and can't get vaccinated. They help pregnant women who may not be able to get vaccinated. They help the economy. There was a University of Utah study that showed that people would be 13% more likely to go to a store if confirmed COVID cases fell by 10%. They found people would be 51% more likely to go to a store if everyone was wearing a mask. So you have this economy versus health argument out there that is a false argument. It's a false dichotomy. The studies actually show that when we practice public health measures like vaccinations and like the 3 W's, wearing a mask, washing your hands and watching your distance, the economy does better. Schools are open. More people feel safer traveling. Understand that health is good for the economy. Masks mean business and vaccinations mean a quicker return to normalcy.
U.S. Surgeon General Dr. Jerome Adams, thank you so much for joining me today.
Always a pleasure. Thank you.